Good morning, everyone. Yeah, so good morning. Thank you very much for joining us for the Syria Health Research Conference, which is done by the R4HSSS Consortium project, which is funded by the NIHR, and that in collaboration with MIHAD ex Osam France, the Syrian Public Health Network, the Syria Research Group, and Health and Humanitarian Crisis Center at the LSHTM. We are very grateful for you joining us here, whether online or face-to-face in person. As you all know that entering its 11th year, the Syrian conflict is still one of the most devastating humanitarian crisis in the world. And while the humanitarian health response has tried to alleviate some of the suffering, it is important to draw lessons on health needs, response, and consequences of this conflict. Of course, at least for us, we believe that research plays a very important role in illustrating these lessons, which could help in improving the health response in Syria and elsewhere. We hope that this conference would be an excellent opportunity for us all to just talk about some of the amazing work which is going on right now that focuses on health system strengthening in Syria, so that we can get some lessons learned and we can see how we can apply them like somewhere else, given that, as we all know, unfortunately, conflicts are just getting more and more intense and protracted, and we need to find certain solutions. And unfortunately, but it's the case, maybe Syria could be a place where we can get some lessons which are learned. So allow me to start the day with welcoming Mr. James Watt, an ex-ambassador, and he's the chairman of our International Advisory Board of the R4HSSS. He's going to be talking on the behalf of Professor Priti Patel, who is the principal investigator of the project, but unfortunately she couldn't join us at this moment. James, board is yours. Floor is yours. Yeah.
Thank you very much, Asil. Good morning, everybody, or hello, everybody around the world. I believe there's 145 people online, so welcome to you, but also welcome to our lovely audience here who've come on this bright, sunny morning in London to join this conference. And I'm just thrilled to be here. I'm very honored to be asked to stand in for Professor Priti Patel, and who I hope will join us later in the morning. And so quite unprepared, I just want to tell you a little bit about how I see the work of R4HSSS and all its partners, and why this conference is important. My own background: I'm not a researcher, I'm not a clinician, I'm not an academic of any kind. I'm simply an ex-ambassador. I served a lot in Middle Eastern countries, and I've been following with great attention the conflict in Syria and conflicts elsewhere, and following with a huge admiration the work of the Syrian and other medical and health professionals who've been fighting so hard to bring public health and medical care to the population outside the reach of the government in Damascus. And I know that there are, I believe, 7 million people living in that situation outside the control of the government of Damascus, and therefore without recourse to the normal state-organized healthcare or other public services. And I know how brilliantly the, as it were, civil society of Syria, with help from many friends and partners outside, has organized healthcare, and that the great things have been achieved, but the great gaps, of course, great lack of resources, lack of personnel, but there's no lack of good ideas. What's really struck me is what wonderful practical real life experience our Syrian colleagues bring to the rest of us from the 12 years in which they've been fighting. Fighting is not the word, they've been defending themselves with peaceful means and medical means, but been struggling, let's say, to look after the needs of the Syrian population in great distress and in conflict. I've always believed that the fundamental purpose of for SSS was to bring that experience of our Syrian colleagues to the wider world, to make it available to those who study conflict and post-conflict situations, and to make it available to those working in other conflicts so that they can also alleviate the suffering of the civilian population as best they can. It's a very big picture, of course. Public health is one part of the wider struggle that society has in conflict and in trying to recover from conflict. I always say you don't actually recover from conflict. You might survive conflict, but things have changed in the course of the conflict. You're not starting from where you were. You're starting with a new reality. And above all, the human reality that there's been a great deal of suffering and trauma. And however bravely people cope with that, those scars do continue, often for 2 or even 3 generations. So every war is an utter catastrophe. Every war is unbearably cruel and foolish, and yet we seem to get more and more of them. Syria is a particularly tragic example, and it's interesting that the conflict in Ukraine, the war in Ukraine, has brought the spotlight, as it were, of public opinion, public attention, back to what has been happening in Syria all these years and what continues to happen. And I think there's more understanding, more sympathy than ever before for what the Syrian people are suffering, and the importance of finding means to deal with this. So briefly, my own background, I was a diplomat. I looked at things from the political security point of view mostly, but now since my retirement, very happy to have retired 8 years ago from the British Diplomatic Service. I've had the chance to work with wonderful colleagues here at King's College on other projects as well, but all connected with, as it were, what happens in conflict and after conflict, and how society can mend itself, how society can grow again and protect itself, protect its children, protect its future. It's very inspiring. I was delighted to be in Gaziantep in September. For the first time, we managed to have a face-to-face conference of R4SSS, because COVID had prevented us really from doing that until then. We're now in our 3rd year of the project, but this was the first time we'd all met face-to-face. And it was very inspiring to see the quality, the human quality, not just the professional quality, but the human quality of all those working to provide healthcare, to provide some kind of support and solace for the population of Syria. Both those IDPs and living still in the opposition-held areas, and those who have crossed the border into Turkey, and of course those who are in a similar situation in other neighboring countries such as Lebanon and Jordan. I don't want to go on too long because you need to get on with your research conference, but I just want to set the context as I see it in a very sort of broad, non-specialized way. This is hugely important in political terms, political in the sense of what does it mean for how states operate, how they treat their citizens, how they deal with each other, and also how states such as the United Kingdom, which have donor money to give, have aid programs, how we should be directing those funds. And one of the wonderful things about the R4HSS program is that it is actually ultimately going to feed into the policy of donors, the British government's own aid program, but others as well. And we're consciously trying to help formulate the policies. Where will you spend the money and what for and under what conditions? Making it as responsive as possible, making it as realistic as possible, and giving full credit to the experience and the drive and the commitment of our colleagues, our Syrian colleagues in this case, the Syrian conflict, but any, as it were, local actors and their supporters who want to do the best thing possible and who are sometimes frustrated by the way in which donor agencies and NGOs can be very prescriptive, can be very narrow, if you like, in the way they try to set terms for the aid they're giving. We're trying to change that. And I think we are. I'm confident we're on a very good track. We're getting fabulous feedback from our funder, the National Institute of Health Research here in the UK, who's described our project. I think they said it's the best they've ever been funding and managing. We got really heartwarming feedback from them just a few weeks ago. So that gives me great confidence. The money is not there forever. We'll have to find other money, but that's the kind of job that I'm supposed to do, trying to raise new funds. But we're very confident we've got a total gold star rating from our funder at the moment, and that bodes well. That promises well for the future. We hope to continue this project, and of course, our collaboration with the various partner organizations. I'm absolutely delighted to be with them and take this whole effort further and on for as long as we can. There's an endless amount of work to do, but we have made a good start. Thank you all very much, and I'll hand it back to Nasim.
Thank you very much, James. Given that you weren't prepared, you had a great speech, really. Thank you very much. And now we move to our keynote speaker. I'm glad to welcome Professor Sophie Witter, who is going to be joining us online. Sophie Witter is a professor of international health financing and health systems at the Institute for Global Health and Development and at Queen Margaret University, Edinburgh. She is a health economist who has worked in global health for more than 30 years, focusing on financial access to health worker incentives, evaluation of complex interventions, health system strengthening resilience, and getting research into practice. For the past decade, she has focused much of her time on health systems in fragile and conflict-affected settings. Professor Witter, are you with us?
Yes, I am. Can you hear me?
Yeah. Yes, we can clearly hear you. Please, the floor is yours.
Brilliant. Thank you very much. And very moving to follow that speech. And I take particularly the phrase, every war is a catastrophe. It's very resonant and yeah, serious moment for all of us. So thank you very much. So I'm going to be talking today, and I hope it will sort of frame some of the more detailed research around Syria that's going to be presented. Just generally about health system strengthening and early recovery and some lessons from other settings, and then bringing it into focus a bit in relation to Syria. But I'm not going to be digging deep into some of the work we've been doing in Syria, because I think some of my other colleagues, Giulia and Ibrahim, will be talking to that later in the day. So I'm just going to start by talking a bit about the concept of health system strengthening, what it means, how it's defined, kind of what we know about what works, and how this links to the early recovery phase. And then I'm going to be picking up some of the lessons from the wider literature around health system strengthening in sort of post-conflict settings. And obviously, as we've been hearing, the term post-conflict is a very ambiguous one. But really bringing out a few lessons for the Syria context from that. So just to start off with health system strengthening, it sounds like it's a very intuitive concept, but and it's indeed one that's had a lot of interest. But a review that we were involved in for the FCDO, looking at evidence, the evidence base for it, really brought out the fact that the definitions for it remain contested. And the origin of the term itself really came from more external agencies, so not so much within the health system, for example, planners and ministries of health, but more the global health initiatives who were investing in different areas of programming. And then this idea of monitoring the broader impact on the health system came out. And what our review from 2019 highlighted was that really a lot of the studies of health system strengthening have come from these agencies and have been quite focused on specific programs and not necessarily looking at the whole system and wider impacts of their interventions. So there is a kind of contested background. So out of this work came an interagency collaboration, which has just happened really over the course of the last year or two, where we try to look at health system strengthening as a concept, but also get interagency agreement and consensus about how to apply it and how to measure it. And this was led by Secretariat at ITAD, so if anyone's interested, I've sort of put the web page on the bottom. We've tried to come up with a kind of consensus definition of how do we measure whether something really is health system strengthening or not. And three key terms were agreed on. So one is looking at the longer term. So health system strengthening should have impact beyond a project, and that broadly means beyond, the kind of 10-year period of time. It should also aim to change relationships within a health system. So this is trying to distinguish from a kind of health system support modality where you provide inputs, but actually the way in which the different system components work together isn't necessarily altered, which is very appropriate in some settings, but doesn't then qualify as health system strengthening. And the final area of the definition that was agreed on, which is very important, is that there should be a focus on sustainability and transition, a focus on building local leadership of local institutions, and working in line with the norms of the local health system. So not an external, imposed model in short. So in theory, the agencies, which includes Global Health, the Global Fund, Gavi, GFF, USAID, all the agency, FCDO, all the groups who are involved are kind of signed up to this definition. And just to highlight another piece of work that came out of this initiative, we tried to, and I realize this is a very complicated slide and I'm not going to talk through all of it, but we tried to think about what exactly a strong health system looks like. So how do you assess it? Because many projects, as you'd be very familiar, probably start with a focus on the inputs, and they're very interested in the health outcomes that come. And what's sort of in the middle in terms of the effects on the system has been a little bit of a black box. So what does a strong system look like? We came up with 22 different goals, which we've grouped under these 4 domains of ownership, participation and accountability, learning and resilience, use of resources and service delivery. And they are kind of ideal. So a little bit like universal health coverage, they're attributes that you're aiming towards. You're never going to fully reach, but you should make sure that all of your investments or interventions either move you in the right direction towards these, or at least do no harm. And you should be trying to look at them as a whole. And the reason for that is that the system is interconnected. So even if you're just investing, for example, in health workforce, you are going to be impacting on all these other areas, because that's the nature of a system, that it's dynamic and interconnected. So we've tested it out in a couple of case studies and think it's a useful, even though the attributes are quite broad, we think it's a useful monitoring learning tool for use, in a participatory way by agencies funding or implementing health system investments. So the overall evidence base, I'm not going to go through it in detail, but we did highlight that there is in fact strong evidence for some areas of health system strengthening. And overall, there's also a lot of evidence around the opportunity costs of not investing in health system strengthening. But there is always this challenge that any system investment is very contextual. So it becomes hard to, to generalize from one setting to another, because the processes and the mechanisms of change will vary. The software of people working in the system and the relationships between them are really critical to how these work or don't work. And of course, history. So the experiences you've been through will be extremely influential in how people react to any kind of, training or model or project intervention in general. And of course, the Syrian example makes that very, very clear. So we did highlight some factors that typically support more successful health system strengthening. And these are quite, intuitive in a way, but clearly where you have more political commitment to a process, that's very helpful. Where it's working with a kind of agreed set of societal values, where the commitment is sustained, so not just a short-term investment which then stops after 2 years, where the programs are coherent, so you don't have divergent goals. Clearly, the quality of implementation is absolutely critical. But community engagement also came out as a very strong supportive factor, and the role of capacity development at different levels. And finally, a focus on iterative learning and adaptation. And that's particularly important because these contexts are so complex, and therefore you can't just design a blueprint. You do have to be reactive. And I think the ambassador was just highlighting that's the importance of the responsiveness element, that we learn and adapt as we go along. So out of that, more recently in September came an FCDO pamphlet about what works in health system strengthening, which I'm not going to go through, but I hope will be put up on their website shortly, developed with K4D. And that looks by block at some of the elements that are important, such as, service integration, for example, or civic participation under the governance one. So the conclusion that they drew out of that exercise of the work that was developed with K4D was that, no one size fits all, which is clearly important. So this question of unpredictability, and therefore the need for a more adaptive approach. Also, that health system strengthening is as much political as technical. And so there's a lot of emphasis in the literature on understanding the political economy. And again, in the Syrian context, where that's very complicated, I think that's a particularly important lesson. It's not one-off irreversible, so it's a long-term action and investment. And the funders recognize it's a difficult one. So because there isn't, as I say, a simple template. We also highlighted that the building blocks are clearly very interconnected, and therefore it's not sufficient to invest in just one part of the system. And as I said, when you do, it also affects other parts, whether you recognize that or not. Particularly in the, also a sort of another point is the interdependentness of the different systems. So obviously the health sector doesn't operate in isolation, and especially I think in the kind of disrupted settings that we're thinking about today, the importance of multi-sector, multi-stakeholder engagement has come out. And of course, the need to track and monitor, which I think is true for most investments, but especially complex ones of this nature. So how does all this link to the early recovery period? So the term early recovery is very much one that comes out of the humanitarian literature. It's well understood. As this transitional period from emergency to recovery. And there is both a focus on the short-term needs in this period, but of course also increasingly a recognition that what is done may set a pattern for later development. So in that sense, we have to think about kind of path dependency. We have to think about the kind of institutions and frameworks that are being created and how those will affect the longer term. And that makes it an extremely challenging time for designing and implementing health programs. Of course, also recognizing from the literature that many countries fall back into conflict, and therefore there's often a cyclical process, and it's clearly a challenging and risky time. So when we think about health system strengthening, is it are we really needing to look at the same kind of approaches, same lessons as I just highlighted for the sort of broader, more general literature? And this is something we thought about quite a lot in our rebuild program that was funded by FCDO that ran up to 2018, the extent to which we were thinking more generally about post-conflict countries at that time. But the question was, to what extent are they different, or are they just more intense needs compared with more stable settings, for example? And I think it's a combination of both, is my personal conclusion. I'd be very interested in what other people think. Both that the needs are more intense, but also there are some very specific elements which are different from, let's say, just a low-income country setting. Particularly this issue of the causes of conflict. The causes that led to the conflict are often still there. So understanding that history, understanding the motivation and positionality of different actors remains important in this early recovery phase. But also, as I highlighted, there's really a need to be incredibly sensitive to the political economy, and also to the kind of population dynamics, particularly, for example, gender needs, which often have been really exacerbated through the conflict. Multisectorality, clearly very important because of the whole disruption to livelihoods and so on, the whole system breakdown. And then within the system, the health system itself, there may be specific elements like, for example, whole cohorts of health workers who haven't been trained, so you end up with a kind of break in your health workforce. And as highlighted by the resilience literature, there's often need to narrow down in your response because of the urgency of needs, for example, to focus very much on, the essential elements and preparing for future shocks, because many of these settings are, we know that shocks, while the actual type of shock itself is unpredictable, that there will be shocks is becoming increasingly, sadly, predictable. So the literature around post-conflict settings raises a lot of features of a health system, and I've just put some examples here. For example, insufficient coordination, challenges to equity, lack of mechanisms for developing national health policies, inadequate management capacity, and so on. And these are brought out more generally. And I suppose one reaction to that is actually most health systems face these challenges. So I think this is an example of where it's, what we're seeing in kind of early recovery period is similar, but just to a greater extent, but not kind of qualitatively different from other low-income settings. As I said, I think where there might be some more specific features, for example, around the labour markets for health workers, often we've seen, a depressed production and training, for example, also changes to employment practice, and often, substantial migrations. And this is certainly the case for Syria, where you get accelerated migration out of the health market by the local workforce, but at the same time, a lot of expatriate workers coming in, filling gaps to some extent. And the impact of that is clearly important to the kind of approach that's taken to system strengthening. Just another example is around the kind of switch to employment by the local or international NGOs, the kind of the way in which they can often offer more attractive incentives. So you get a kind of internal brain drain to, or at least change in employment pattern, perhaps put it slightly less negatively, but also the challenge that creates to re-establish kind of administrative systems for health worker employment through local authorities. And as just a final example of some of the patterns that we see in many of these settings, which again I think are all applicable in the Syrian context, includes this influx of international local NGOs. Often the private sector will take up some of the kind of slack in terms of providing services that perhaps were sought from the public sector prior to the conflict. And overall, this creates a kind of challenge of capacity to manage the pluralistic system. So you have, contested authorities, obviously, and challenges to trust in the sort of de facto local authorities, and the issue of how you manage these multiple and often quite powerful non-state actors. And I'm sure these themes will be coming out today. On the governance side, as I said, there is a tension between meeting short-term needs and thinking about long-term programming, but also because of the increased role of aid, you have these tensions between the sort of project base and a broader system-wide governance frameworks, and between state and non-state, and having to think about the kind of alignment between the aid that's provided with community needs, but also that balance of service delivery and kind of capacity development, and how to manage the different aid modalities and reporting, all of which, as we know, can have very substantial transaction costs and cause potential fragmentation in the system. So out of all of these challenges came a set of principles of intervention for the early recovery period, which was developed by a global cluster. And I think you can see, again, I'm not going to go through all of these, but I think you can see that they do try and reflect a lot of that learning and those priorities that, for example, they focus on not just short-term responses, but also thinking about longer-term recovery and addressing underlying causes and building the necessary foundations. So they are well designed to tackle the kind of dual needs of the early recovery phase. And I think, although these are not for the health sector specifically, these are much broader, they're a set of multi-sectoral principles, they do reflect that kind of learning about how to balance our efforts in this stage. So in relation to Syria, as I think just highlighted throughout, all of these lessons from other settings I think are very applicable. So clearly it's extremely fragile. The problem of internal displacement is huge, and the sort of potential transition from humanitarian to development funding and all of the concerns around that, from which we have some literature in other settings, have all been raised here. We do know from studies that have been undertaken, and again, I think some of my colleagues will be picking up some of this in more detail, that there are a lot of gaps in the provision of services. There are a lot of challenges to the health workforce market and indeed to kind of collaborative governance models. We know there's inequitable distribution of services, and there are areas like mental health which have not been well integrated to date in areas where we have research data. And of course, we have this kind of mosaic health system with different authorities and the challenge of shifting borders and different and limited regulatory capacity. And all of that feeds through into low financial protection for users and reliance on aid. So I know, therefore, that many of the presentations today will be digging into these, but you can see that all of these highlight the importance of the health system strengthening lessons that have been brought out. So I think in conclusion, just to highlight that there are both intense and very specific health system strengthening needs in settings like Syria, but also that we do have clear principles for intervention. What we don't have is longer term evaluation, I think, of what works in the settings. So typically we don't have much, because of the nature of the dynamic environment and the challenge for research, we tend to have short-term studies rather than longer-term tracking the sort of impacts over time of system investments. We know that public-private partnerships and related modalities, such as contracting to NGOs, take on a larger role. And we also know that the ensuring financial access is a really key challenge, and that modalities such as cash transfers and various forms of improvement to supply chain management, for example, are really key. And finally, just to highlight that the kind of cross-border, both internally and within the region, thinking and investment is really key in these settings, and again demonstrated in Syria, but also in other kind of similar early recovery phases and complex emergencies that we need to think about, the health workforce, for example, and also around population as being highly dynamic and plan accordingly. So just a few key points there. I hope that provides a setting, and I look forward to hearing the later presentations today. Thank you very much.
Thank you. Thank you very much, Professor Witter. You summed it all. Thank you very much. And now, and thank you again, James. Now we can move to the first session, which is about health system strengthening and early recovery. So Professor Witter explained, as I mentioned, she summed it all. She explained broadly about the major issues which are faced in conflict settings. And now we're going now to see how things are done on the ground, and that from 3 presentations. First, we'll start with Shaymaa Safadi. She's studying a PhD in industrial engineering in Gaziantep. She has been working in the humanitarian field since her graduation from engineering school, working in humanitarian organizations, have had a huge influence on both her education and career. And now it gave her the chance to employ what she learned during her humanitarian field work into her thesis, which is suggesting a new approach in building a medical network in Northern Syria. Shaymaa will be talking about re-establishing of medical network in Northern Syria using multi-objectives approaches, and Shaymaa will be joining us online. Shaymaa, can you hear us?
Yes, can you hear me?
Yes, we can hear you clearly. The floor is yours, Shaymaa. Please go ahead.
Thank you so much. Let me share my screen. Can you see it now? So this is a study I have made during my master degree study in Gaziantep University. It's about re-establishment of the medical network in north of Syria using multi-objective approach. I will start by discussing some statistics and facts. As you can see here is the
Shaymaa, we cannot see your screen.
Okay, sorry.
Yeah, it's fine. No worries. Yeah.
How about now?
Now, yes.
Yes. Let me. Yeah. So the case is taking place in north of Syria in the area of the areas of opposite functions in north and northwest of Syria, and according to the final reports, the number of people who there are more than 63% of the population need for humanitarian help after 10 years of war, and there is 6.6 million people are IDPs, and 3 out of 5 are displaced people. Through the 10 years, there is more than 700 NGOs has opened in the NGOs have opened in north of Syria, and up to now there is more than 150 NGO are working there and providing services in different fields, including the medical facts, but the amount of services cannot cover all the population there, and as well as there is misdistribution for the amount of money flow in this to the systems, as well as the resources, the allocation of the patient to the systems. There is a lot of issues that should be considered for the medical network. So here I have tried to make a research or an approach in order to provide a tool, a mathematical tool that can help decision makers in the future to help them to give an effective tool or an effective solution and build an optimum medical map by taking into consideration other criteria such as the cost of opening a facility, the transportation cost for a patient or a single patient from its place or to the medical center, as well as the number of facilities to be located and the resources to be used. As I said, the mathematical tool technique will generate a model to fulfill multiple of goals at the same time by opening a limited number of medical facilities. Up to now, there is more than 500 facilities that are working in north of Syria and northwest of Syria, but all those facilities cannot cover all the population. So we are considering this too during this research. The criteria to be considered, as I mentioned, the cost, the transportation or distance, as well as the type of facilities, medical facilities to be opened in the area. The research methodology will include four stages. Starting by a linear programming, we are converting the real problem that's happening on the field into a mathematical problem. And by defining the parameters, the objectives or the goals that should be achieved at the end of the research, as well as the borders or the constraints of the problem. The second stage will include an multi-criteria decision making. This methodology will be used to rank our objectives. As I mentioned, there are more than one objective to be achieved at the end of the research, including the cost, the coverage of the people, and so on. And the third one is a weight goal programming model. This model will try to minimize the deviation even for each of the goals. For example, if we have an overachieving or underachieving for each goal, we are trying to minimize it. Then we are introducing the data into the system or into the model, mathematical model, in order to get our results and analyze them one by one. The data needed to build this model is the number of people to be covered, or the population, their concentration in communities and districts, the capacity of facilities to be opened in this medical network, as well as the transportation cost and distance. With the help of 10 experts from different humanitarian help, from different humanitarian fields and NGOs, we have decided to open 6 different medical facilities that provide 6 different services, including second healthcare centers, primary healthcare centers, productive health centers, COVID-19 vaccination centers, and blood bank centers, dialysis centers. The assumptions or the borders of the models are demand node is served only once. What we mean by a demand node, if every single community or district to be taken into consideration during this research. And it cannot be served once. We mean that we cannot open the same 2 medical facilities at the same location that can serve the same community at the same time. The second one is the concentration of people. We need to know the concentration of the people and the location of each district. And the third one is the location must be accessible. What we mean that the location of both the medical facility and the community at the same time. So in case of wars or in case of fightings, we can reach those facilities or those centers. And here we have suggested that the maximum distance from a single district or single community into the medical centers should be less than 2 kilometers. And the final one is the cost allocation for all the patients should be the same for all the facilities. Now we have converted it into a mathematical model. As you can see, we try to maximize the coverage, minimize the fixed cost and the transportation cost, taking into consideration the distance, as well as maximizing the number of medical facilities with each type. And it's subjected to, or our constraint is we have chosen a limited amount of a limited number of facilities to be opened. The coverage of a single facilities of a single district should be 1. And the capacity the demand cannot exceed the capacity, and so on. The second stage is a multi-criteria decision-making. This process has been an effective tool to help the decision maker taking decisions in any facilities or business, and as well as in ranking the objectives for a single problem. So here we have many. We have many goals, including the cost, the number of facilities, the transportation, and so on. So we need this criteria to know which goal should we start with, which goal is the most important goal to be achieved at first. So we have used AHP process. Why we use it? Because our goals are independent from each other and doesn't affect each other. And the second one, because the participants participants or the experts who have taken this survey have their own point of view or their own perspectives and preference. So the AHP is more applicable here in this process. How we are applying this by doing a pairwise comparison, and this by giving relative importance points by comparing two goals to each other, giving their number. For example, 1 is equal importance, 9 is extreme importance. Here you can see one of the surveys for the 6 experts who have participated in this survey. In the yellow square, you can see that he gave 5, which means that the maximum number of people to be served is more important than minimizing the total cost or minimizing the budget. So and so on for all the other goals. After we get 10 matrices, we should gather them in one matrix, and this one is used, and it's gathered by using a geometric mean, or the equation in at the end of the slide. We get the one final matrix, and after we get them, we should check the consistency. We need to check the consistency in order to know if all the experts have the same behavior or the same point of view in terms of this survey. If our consistency is more than 0.1, so we need to do the survey again by taking into consideration giving more goals, or doing changing something in the structure of the research. And here you can see at the end we have a consistency is less than 0.01, and the most important goal to be taken into consideration is maximizing the number of people to be served, or maximizing the coverage with 42%. And we should ignore or don't care a lot about the minimizing the total cost or the budget of this work. The third stage is weight goal programming. This process is applied in order to because our constraint is soft constraint, so we want to achieve and fulfill those goals. So by minimizing the deviation from underachieving or overachieving of each goal, and that can be done by adding a penalty cost for this problem, for each goal of the problem. And you can see that we have added a new objective function here by adding a penalty cost and the deviation index as well for each target value for each of the objective functions. Finally, after we have done the model, we need to introduce it, or introduce the data into that model. The case study, as I mentioned, is in north and northwest of Syria, in an area of more than 33,000 kilometers squares, and the population to be considered is 4.5 million people, including 11 districts and 135 community. Here there is a more than 400 candidate place or location to be considered, or to be is a potential location for opening a new facility. And as I said, there are more than 4.5 million people to be covered. The budget that's been dedicated for this research is $2 million. And the number of facilities or medical facilities to be opened at the end of the research should be 115. And the capacity of each facility or medical center will be between 10,000 to 25,000 units. As a result, after we used optimization package and the geographic information system, we got our results, and as you can see, all the objectives or the goal of this study has been fulfilled totally, or up to 99%, except for the population coverage, and that is due to limited number, or because of the limited budget. And the model was able to cover more than 219 demand node or community. And as you can see on the map, that the locations or the demand nodes that are covered are in the location where the concentration of people are high. And as I said, the number of people to be the number of facilities to be opened are 115, and more than 2.5 people were covered out of 4.5 people. Here, as a result, as you can see, the model, as I mentioned, tried to locate its centers at the high concentration districts. For example, the model was able to open 39 SHC, 17 blood banks, 92 COVID-19 vaccination, 112 PHCs, 93 reproductive health and maternity care centers. And as a conclusion, the study is one of its kind on the Syrian land, and it's not applicable in Syria only, because we have used it. I have used in this research the GIS, Geographic Information System, and the optimization package. The data are real, and you can by using those by using GIS you can apply this anywhere in the world. Also, the model wasn't able to fulfill and achieve all the goals, but due to the budget or the limited capacity of the facilities, because the capacity used in these facilities are driven from the real data and on the field. So if we had we tried to increase the capacity of the centers or increased our budget, we can achieve more optimum results. We can for further study, we can add cash for work, and we can add salaries for the laborers. I really hope this study can help the NGOs, donors, decision makers to provide a more efficient, more effective services in the future, and can be an effective way to increase the quality of the medical help in north of Syria, especially during these hard times. Thank you all for listening, and it would be my pleasure to answer any of your questions if you have.
Thank you very much, Shaymaa. Do we have any questions, whether online or those who are with us today here? I do have a couple of questions, so.
Well,
okay. Is there a question from those joining online? Oh yeah, there are two participants who raised hands, so yeah. Zahid, can you please check so that we can... Please, for the one who raised their hand online, can you please ask your question?
Yeah, sure. I just wanted to ask about the capacity about the project. Regarding the medical workforce, is the university or the medical schools there able to, let's say, provide efficient medical workforce or health professionals to cover all these nodes or all these areas? Because, like, according to information, there isn't like a lot of like medical schools in these regions. So where did you get your health professionals?
Health professions.
Yeah, like medical workforce. The medical work. Where do you intend to get the medical workforce? All these numbers, because these nodes need like huge number of like professionals, doctors, dentists, nurses. So where are these going to be like trained? Where were these trained, and like where will you get them?
Well, at my research, I really didn't take into consideration the training or the employment process, as I understand from you. But my research has concentrated on building the facilities, using the money efficiently and the resources efficiently in building the facility. One of the I have said that there is a limited capacity, and this limited capacity because all of the laborers or the workers are trying to get out of Syria to other countries or to other places where are safe places, and that's what one of the reasons why there is a limited capacity in this research. And as I said, the data for the capacity are real, so I'm trying to provide a real tool that can be effective.
Yeah, thank you very much.
Welcome.
Is there is another
Yes.
question?
Yes.
Yeah, please go ahead.
First of all, I want to thank you, Shaymaa, for this interesting presentation. I know that at least in the current time being, most of the estimations for opening new health centers is based at least partially on severity indexes and mapping done through the humanitarian needs overview. And what you are presenting is a much thorough mathematical model to be more precise in doing this. What I'm asking is whether you are planning, to compare the actual distribution of health centers right now in the area with a suggested model to identify or see how much deviation there is in reality from this optimal model that you are doing right now. And maybe we can understand if there is a reasoning for such a difference, or maybe this is just a gap that we need to try to look for and fill it. Thank you.
Yeah, well, I have tried to search for the real map on the world, but you can see that in a conflict area such as north of Syria, where there is fighting all the time, the places or the location of the real facilities or medical facilities are not announced clearly. So I have gathered the number of the facilities that are now working, including the PHCs and CHCs and so on, and tried to compare them. So I said there is more than 500 facilities that are working north of Syria now, but the location, it was, even for me who is working now in humanitarian field, was hard to get all the locations. I think it was gathered only by WHO, and they refused to share it with me because I'm using it for an educational purpose. So that's the reason. So I have tried to only get the data and try to explain them here. But really, if you can get the real map, you can share it with me, and we can take a further studies for the future.
Thank you, Shaymaa, for doing all of this work despite all of the challenges that you've mentioned. Access to data, one of them, of course.
Yes.
The last question I'm going to please keep it. It's one of those that whereas online. Can you please clarify what a budget of 2 million is expected to cover in these 115 facilities? And is this only for primary healthcare facilities? Yeah, it was one of my questions, actually. So the $2 million, I would assume, what would they cover?
Well, will they cover the transportation cost, the fixed cost of opening the facility? So I am not using a facility that is already open. I'm trying to open a new facility. So we need the money to open a new facility, of course. So those $2 million are used to open facilities in different locations, including getting the running cost and the cost of getting the materials for different types of centers.
But this is a low cost, right? Like 2 million.
And that's what is shocking, actually. I didn't expect to be able to open 115 facility with a budget of 2 million. Of course, I didn't mention the cash for works or the salaries in this model, but only opening a facility, yeah.
Okay. Thank you very much, Shaymaa. We are a bit late, which is totally fine, but thank you very much for your work. This is very interesting. This is the first time for me I see like these mathematical models which are applied for such contexts, which is very interesting. So we move to the next presentation, which is going to be done by two researchers. Amina, Olabi, and Giulia Loffreda. I hope that I spelled your name right. So they will be talking about community perceptions of healthcare service delivery in North Syria, exploring the current and potential roles of the private sector. This is very interesting. So I'll first just introduce Amina is a public health professional focusing on areas of conflict, including Syria. She holds a master's degree from the Liverpool School of Tropical Medicine, International Public Health. She worked on several research projects ranging from investigating the outbreaks of infectious diseases in Syria, maternal and child health studies, health financing, research, and health system strengthening initiatives with various academic institutions and NGOs. Amina is a member of the USAM France, which is now its MIHAD headquarters team, focusing on the research aspects of MIHAD's work. She is a founding member of this annual conference series as part of the organizing committee. Giulia is a health policy and systems researcher at the Institute for Global Health and Development at Queen Margaret University, Edinburgh. She is part of the Rebuild for Resilience Consortium. Her research focuses on health system resilience and strengthening governance, community health systems, and more recently, ways to foster climate resilient health systems. She is a pharmacist with a research master's in public health and currently conducting her PhD on the political economy of non-communicable diseases policies using complexity theory and science. Please welcome them both, and the floor is yours. Yeah, sure. Here. I am not. I don't know. So you can, yeah. Okay, and you can use, of course, you can use this one. So please go ahead.
Amazing. Thank you very much, Nasim. So today our study that we're presenting is on community perceptions of primary care in Northern Syria. This is a collaborative effort between Queen Margaret University, represented by Giulia, and we also have Ibrahim, the PI, online. It was also in collaboration with Madmar, and my colleague Maher is online as well. And us, as Mihad, previously known as Awesome France, with support from the Rebuild Consortium as well. So just a bit of a background story about how this work came about as well. So as we know, in Northern Syria, both mainly also in Northwest, the NGOs have kind of taken the lead on the humanitarian response for years now. And we know very little about the other sectors, specifically about the private sector. And we also know that previously in Syria, the private sector was quite strong, quite dominant. And so it's interesting to kind of see how the two sectors interact, specifically now in a climate where a lot of NGOs are losing funding and there are concerns around continuation of services and access to for communities to reach health centers. So we kind of started with a hypothesis of whether the private sector could work in complementarity with the NGO sector to continue providing a sustainable health response.
So you have, yeah, you can use this one.
Okay.
And
perfect.
You can read from the screen.
Amazing, thank you. So just a bit of background, we'll hear a lot about the background in Northern Syria. So our study worked on Northeast as well as Northwest Syria. And as we know, it's a very fragile setting. There's been years of kind of fragmentation of the health service provisions as part of overall a fragmentation of the country. And we know also from the literature that when situations like that arise, there's often an empty void that's left that could be easily filled by commercial providers. And obviously that raises serious concerns around equity of health services. Therefore, we started looking at kind of whether private sector engagement could be a more kind of equitable and long-term approach for healthcare provisions in Syria. The rationale behind our work is there's a kind of increased global attention on private-public partnership and private sector engagement activities. And we saw that now with the COVID-19 pandemic, where a lot of countries started collaborating with the private sector to try and achieve universal healthcare coverage and for healthcare outcomes overall. Specifically in conflict states, however, that tends to be quite difficult, obviously, because there's a lack of policy frameworks in place and a lack of also data and monitoring work. In Northern Syria, as I said, the private sector has not been assessed, but it exists, and it's obviously also still working in those areas. So it's important to understand its role, and we were hoping also to kind of provide some more evidence about how the private sector can be engaged in complementarity with the NGO sector. So this current study is a follow-up study. So we did a phase 1 study, which was qualitative, and we looked at the private sector engagement potential activities with the provider's perspective. So we did interviews with providers as well as a literature review. And we found the following kind of themes emerged. So the theme of governance was a major one, specifically in Northern Syria, where stewardship is a real issue, because obviously to do these kind of collaborations with the private sector, you need a governing body to also ensure the quality of the services that are provided by the private sector are in line with the standards. We also had an issue around the health information system. So both in Northwest and Northeast, the current health information center system is centered around NGO data. However, the private facilities don't report to that, which is an issue as well. Again, the point about quality is linked to the regulation point. So who would really take on that role? There's different efforts, I know, from different health directorates to kind of provide that regulatory framework. However, they're kind of sporadic, and there's no systemized way of ensuring quality services, specifically within the private sector. Also, the issue of human resources. So I think we'll touch on that as well. So the idea of dual practice with people kind of shifting now between working at NGOs and also at the private facilities, and what does that mean in terms of quality and in terms of the idea of continuation. We also looked at health financing, and we found that obviously the response is quite donor funding led, and out-of-pocket payments remain a real issue. So the study objectives for the phase 2 study, phase 1 was focused on the provider's perspective. Phase 2 was hoping to look at the community's perspective. So if we did want to engage with the private sector, what's the community acceptance of that? So the 3 objectives are there. So we looked at the utilization and the perception of primary care within the communities. And we also looked at the preferences of communities regarding pathways to care in different sectors. And finally, we kind of mapped those against the socio-demographic characteristics. Our method used a multi-stage random clustering sampling technique, and we used a community-based survey. So the questionnaire had different elements. We looked at the socio-demographic characteristics of the sample. We also asked participants about the health service utilization accessibility. We looked at the availability and perception of the overall quality of services for selected conditions. And finally, we investigated trust in the private healthcare system. We recruited a total of 1,919 community members, of which 57.9% were in Northwest and the rest were in Northeast. And for the analysis, we used descriptive and bivariate analysis. The sample was, so the mean age was 39 years of age, and it was predominantly men because we were interviewing household heads. However, we tried to kind of compensate for that by adding a different household. So we surveyed a second household member, and we got a better gender balance there. It was, I think, almost 50-50. The highest percentage of participants had high school certificates, and there was big differences between Northwest and Northeast in terms of resident status. So the majority in Northwest, 56% were IDPs, and in Northeast, we had 17% of IDPs. We also obviously had a much higher camp population in Northwest. So it was 18.5% and a very small camp population in Northeast. You can also see the crowding index of 3.7 persons per room as a total. Giulia, if you'd like to. Yeah.
Okay, thanks so much, Amina. I'm going to take you through some of the findings of this research. So we ask community members about their health needs and the service utilizations. So we ask if they actually needed healthcare services in the last 6 months, and 86% responded positively to these questions. And among those 86%, we ask what was the first source of healthcare. And the some of the options of these questions were the NGO-run PHC, the private clinic, private pharmacies, public and private hospitals, and we differentiate between ER and admissions. On the x-axis, you can see the percentages of responses. And the two main responses were NGO-run PHC and private clinics. And for Northwest Syrians, the first source of healthcare was the NGO PHC, while for Northeast Syrians was a private clinic. Also, the most common healthcare need was an infectious disease, followed by chronic NCD. We then ask about the affordability of the services, and we ask community members if they consider private clinics to be affordable on a scale from 0 to 5, with 0 being not at all affordable and 5 being always affordable. In this case, the majority of Northwest Syrians, specifically 38% of them, consider them sometimes affordable, while the responses were a bit more mixed for Northeast Syrians, being like they consider them sometimes affordable, mostly affordable, and always affordable, somehow in equal measure. We then ask about the private hospitals. And while you can see a clear trend for Northwest Syrians, which is the light blue line, and the majority of them considering them not at all affordable, for Northeast Syrian, the picture again is a bit more mixed. So the responses were mixed. So like a percentage of them considered not at all affordable, some rarely affordable, and then another percentage always affordable. We investigated trust, and we asked questions, 8 questions, specifically around 8 domains based on the OSAVA framework. And we investigated trust. These 8 domains were around communication with the providers, qualifications of the providers, and other domains around trust. In this case, we ask if they consider the communication with the providers with the private providers to be better than the public and NGO sector. And in this case, 42.5% of the total respondents, so in both settings, agrees that the communication with the private providers is better in the private sector. This could be that we have been thinking about the reasons behind this. And since the private sector in Northwest is actually less present there in Northeast, this could be due to the fact that actually Northwest Syrians have less interactions with the private sector. So maybe they trust it more because they have interacted less with, this is just a potential explanation. Then we ask about the private health providers' qualifications, if they considered actually the private health providers to be more qualified and competent than the public NGO sector. And in this case, 39.8% of Northwest Syrians disagree that the private providers are more qualified and competent than in the public NGO sector. We finally ask about the trust, if they trust the private healthcare system in Northern Syria. And this was not a comparison with the public health sector. The Northwest Syrians actually agree that they trust the private healthcare system more in larger measure. So for maternal health, we investigated if there was a delivery in the household, and 678 participants reported in this case, the majority of the delivery were vaginal delivery, with around 35% being C-sections. And in this case, we also asked community members where the delivery took place. And while this delivery in Northwest Syria, the majority of those happen in the public hospital, in Northeast Syria, this happened predominantly in the private hospitals. And also there is quite a larger percentage of this delivery that took place with the traditional birth attendant in Northeast Syria, which was also quite interesting.
We also looked at the factors affecting the selection of the health provider, and we did bivariate analysis to see how that mapped with the socio-demographic characteristics. And we found that employed respondents were more likely to obviously go to private clinics and private hospitals, and people who were more reliant on cash and in-kind assistance were more likely to visit NGO and public hospitals. People with salary jobs also reported a higher use of private clinics, which is expected, and also IDPs there we can see were more likely to utilize NGO-run facilities. We also looked at different conditions. So we gave different scenarios of, if you had a child with an infectious disease, where would you go? And we found that infectious diseases, specifically, participants would seek care predominantly at NGO facilities. And one clear trend was that private clinics and private hospitals were more utilized for antenatal and gynecological consultations in both areas. We can also see that orthopedic and other surgical consultations were mainly done in public hospitals, which makes sense because maybe also the cost of them in private facilities would be a lot higher. Some additional findings, but I know we're running short on time, so I won't go into that much detail with these ones. But we also mapped out geographically the availability of private providers in different communities to see whether this idea of geographical access could be also increased by contracting and collaborating with private providers. And indeed, we found that the private providers, whether private GPs or private specialist clinics, were more dispersed within a community. And there was a link between the fact that they were closer to community members and the fact that, it was associated. So the closer the space, the more the participant was likely to utilize that service. We also looked at the role of pharmacists as a potential entry point, as they are kind of often the first entry point to a healthcare service, and we can go more into that later on. Did you want to go through that conclusion?
Just some concluding remarks. So I think we added to the body of evidence on the role of the private sector. I think there was not a lot of information in this regard, particularly around reasons and perceptions about using and utilizing private services. We found the higher utilizations of the private sector in Northeast Syria, and particularly for some services such as antenatal care and gynecological services. We found inequalities in the uses of services across sectors based on specific factors. This is in line with the international literature, so such as IDP status, unemployment, and low income level. And also kind of the risk of commercializations of the health services by the private sector, specifically because we found that, for instance, the majority of the C-sections happened in the private sector. So really the importance of dealing with fairness and vulnerable populations. Usually it's not a concern of the private sector. And just some overarching remarks also based on the first phase of our project, and really stressing the importance of identifying effective governance strategies and integrating this into the overall health system goals and health system strengthening approaches. So the importance of accountability and transparency and leadership. And in this case, the stewardship role is absolutely essential for any engagement with the private sector. But who can play this role in the Northern Syria? And I think we hinted at this before. I think we'll discuss perhaps more. And the importance of planning and strategizing since the beginning, any type of engagement with the private sector. This is important, particularly to avoid any unregulated growth of the private sector. And the importance, as Amina mentioned before, also the dual practice of the doctors. We didn't investigate this aspect. We just focus on the community members, but also understanding, for instance, working hours, but in general, regulating the dual practice. It's quite important. To map the scale of the private sector also, I think will require this information. And then the health financing aspects, of course. So inequality, as I mentioned before, also as Sophie mentioned before, the need to address proper health financing strategies. This could be done, for instance, through voucher systems. It's probably a suboptimal approach, but it's there are examples from other countries, and there is need to explore those aspects. And then finally, just there are other aspects important, but I want to touch those. But I think, again, stressing the importance of the commercializations of the private sector. I think this we see this globally happening, and also in the EMRO region, I think it's quite widespread, the commercializations of the health system and private sector. So it's really important to avoid those this to happen, and then ensure dialogue and build trust among the sectors. I think also we conducted some workshops in Gaziantep, and we saw, I think there is there is really need to build trust across the sector and ensure the dialogue and engage all the key stakeholders. Thanks again to Dr. Ibrahim Bourm, who is the principal investigator for this project, and the other colleagues. So I'm not sure if he wants to add anything, and if there are questions also, happy to answer those. Thank you.
Okay, I'll move there. I'm loud, so I can, that's just for those online. So thank you very much for this very interesting presentation. The researcher inside of me wants to ask you a lot of questions, but probably I'll give the floor to other people to ask you. I just want to highlight the fact that you're covering two issues which are very important. The private sector, which is not, it's something which is not that discussed in the literature, and northeast of Syria. You barely find anything about northeast of Syria in the literature. So it's good that you actually covered northern Syria in general, which is very, very impressive. So any questions? Yes, please. Yeah, sure.
Also, thank you then for covering those. No, sorry, just that you should elaborate a little bit on the kind like more access to private sector in Northeast economy, or just because there is more trust in the public part in East.
Maybe I'll just start off and then see if colleagues online can.
When was the research conducted?
So it was just a few months ago, over the summer period of this year.
The past,
Yeah.
how the economic situation has deteriorated a lot in North Syria.
Exactly.
It has changed also the approach.
Yeah, so the thing is around, we were trying to also discuss this trend of Northeast being more, the private sector, sorry, being more utilized in Northeast compared to Northwest. Obviously, we can only speculate as well because this wasn't qualitative work, but with Northeast Syria, there's obviously less of an NGO presence over the last few years compared to Northwest. So this could also be one of the factors of why, again, going back to the first slide of kind of this empty void being filled by someone, you know. So this could be one of the reasons, but there's different kind of speculations around it, but it's probably most linked to the idea of the NGO presence in Northwest being so dominant, so kind of, you know, taking the lead across all different sectors. But I don't know, Giulia, do you have anything also to add? Or
No, I don't know.
Ibrahim?
Thanks, Amina. I didn't hear the question, but I think from what you answered, I can guess that the question is about the difference in affordability of services between the West and the East. And indeed, as you noted, I mean, we had a lot of ideas that might explain this observation, including what you mentioned, and also the market differences between the two regions. So you would expect maybe cheaper consultations in Northeast compared to the Northwest. So whether the dynamics of the economy as a whole, so you would know that actually, as you said, so unfortunately with the political and economic fragmentation of Syria, especially between the East and the West, you have totally different business dynamics, totally different salary scales, totally different, I would say, community purchasing powers and so on and so forth. So these might, as I said, might explain part of what we thought being considered as a higher affordability. So we cannot say that we have similar communities, then we cannot really jump into saying that communities in the East can afford services just because of their own characteristics. We know that they have different characteristics. It's probably the market dynamics there.
Yeah, and side note, in the Northeast, you also have birth at home, you know? So you have like, they are using the private sector, but they are also having more women actually give birth at home. So it shows like it's totally different from the Northwest, right? So I saw like there's a person online, Thara raised her hand. Do you have any question, Thara?
Hello, can you hear me?
Yeah, sure. Yeah, please go ahead. Yeah, please.
Thank you for the presentation. Just a small question. You mentioned that you did the research in Northeast Syria, but in which location exactly? Is it in Hasaka Governorate or Deir Zor, or if you have the districts that you covered? Thank you.
Thank you. Yeah, it actually covered the majority of Northeast Syria. So Deir Zor, Hasaka, Raqqa, the major kind of governorates in Northeast Syria were covered.
Thank you. And we have a question here. Yes. Please just introduce yourself.
Yeah, this is Hussam Al-Kabani. I'm a master's student at London School of Hygiene and Tropical Medicine, Public Health for Development, and I'm working also with NGOs in the northeast of Syria right now.
Thank you. Yeah.
So my comments on this question, actually, I worked a couple of years in northwest of Syria and northeast of Syria. And this is why I think that this, first of all, this is very interesting presentation. And I think the figures is truly reflecting the actual things that we are sensing on the ground, but without getting this like accurate numbers. So, but this is the first comment and the question. So, like for the pharmacists, it says like 6% of people rely on pharmacists. So can we get this information on geographical levels? Like in Deir Zor, as example, I know that the pharmacist may be the first, point of entry, and most people are relying on pharmacists exactly more than either the private sector or the public sector. So if we can get more information about this. So this is the first question. The second comment and question. Actually, I know that I work both settings, and I know that the NGO sector is immature in the northeast of Syria comparing to the northwest of Syria. And I think this is why people are just start relying on NGO sectors and public sectors, and NGO sectors mainly. So I think maybe in a couple of years those numbers will be changed, especially now with increased presence of multiple national and international NGOs in the northeast of Syria. And the third one, which is if we can go deep, like in the neonatal ICU, actually I saw a huge difference between northeast and northwest of Syria. Like the neonatal ICU in northeast of Syria, it's not really an issue. I'm not sure why. It's not, people may be coming to the private sectors and they are not reported. We are not really getting the information about them. Northwest of Syria, it's predominant that every now and then there is like a maternity hospital and there's an ICU, and the utilization rate is really high. So I'm really curious about this particular issue. So maybe in the future, if you are going to complete this research, I would like to check if this could be a possible things to check on. Thank you.
So he had a question, right?
So I think your question, thank you so much for your comments. I think the question was about pharmacists, right? Yeah, do we have those slides on this version, or should we? Yeah. I think that was one of the slides that we may have, missed for the sake of time, but we can go through it maybe in the break. But it's interesting you mentioned about the 6%, because I think that's also reflective of the whole overall kind of context in Syria. That's the perception about like healthcare utilization being quite of the medicalized model. And so that's why we see that kind of primary healthcare and also pharmacists and even like community health workers are kind of less perceived as the first kind of source or the entry point necessarily for a lot of community members. But yeah, we can take you through the geographical distributions as well. Did you want to add anything?
You're going to publish this, right?
Sorry?
You're going to publish this?
Yeah.
Yeah, right. So of course you should. We don't have a lot of literature about Northeast, so yes. So yeah, we still have time for one more question, and then we'll go for the break. We did a slight change in the program for today. So is there any question, whether here or Karim?
I'm sorry to take in a role of
Oh, yeah.
question, but very interesting findings. And I noticed that you went through the details of provided services. And I think this is really important. And I wonder if your publication will expand on this, because part of the complementarity between private and public sector is really to look at what are the exact services are provided by private sector. For example, in a brief study that I conducted with Expertise France in Northeast of Syria, we noticed that the private sector, they tend to focus on especially the services that are not covered by the public sector to make profit, which I think makes sense. But I think for planning and to inform health policies, I think we need to maybe map out the different levels of care and what are the type of services provided by each sector and how they can be complementary to each other, and whether you've done this in your paper or whether there are plans to do this in the future.
Definitely. Thank you very much, Karim. I think so we touched on this kind of at the very surface level from the community side, so from the demand side, but there is a need to look at the supply side, as you said, and really mapping out. That was one of the recommendations, actually, looking at like mapping out even like the geographical distribution of where the private sector is more present, what kind of services they're providing. So I think we kind of touched on the surface of that, that there is definitely a need to go more in depth.
I wonder if Ibrahim has anything to add, but we also try to explore this during the workshops and asking actually, like, because we had workshop with the key stakeholders, with NGO providers, PHC, and the public and private hospitals. And also they had clear views, like, so the NGOs should be in charge of the PHC, and then the private sector be more in charge of tertiary care. So, but clear there is need for actual data. I don't know if Ibrahim, you have anything to add?
Maybe one last comment to say that, I mean, just in line with what you said and what Karim mentioned is about really what kind of role the private sector should have. So this is just a first attempt to try and see the differences in services provided by the private and the public, because the whole rationale of our work, and also to link it with the conference theme this morning, is to really try and investigate the the health system in Northern Syria in a way to avoid having really parallel health system, in a sense, like where you have a strong private sector just trying to attract a specific clientele as they own the kind of clients for a specific profit-making services, instead of really engaging the private sector in having one system in place, and then engaging the private sector to also support the public sector and the NGO sector in delivering also any different type of services. And as I said, yeah, this is maybe a first step into just having some evidence to know what should be done and how to investigate this more. And that's it from my end. Thanks so much. And over again to you guys.
Thank you very much. Thank you. That was very interesting. So now we're going to have a 10-minute break. You have there coffee and drinks and refreshments. And then when we come back, we'll go, Giacomo will present for us also about Northeast, right? Yes. So yeah, let's go. See you in 10 minutes. Yeah. Martin, 1 minute. I'm just waiting for Giacomo to come back. Here, yes. Okay. So we'll now move to the second session for the day. And we'll also have 3 presentations. The first one, it's gonna be, the title of the first one is Moving Along the Continuum Between Emergency and Early Recovery in Health Systems Strengthening in Northeast Syria. And it's going to be presented by Giacomo Lapo Baldini, who's graduated from Johns Hopkins University in 2016. He holds a master's at from the University of Bologna, and granted 2 scholarships in Australia and Jordan. After a few experiences in think tanks in London and DC, he moved to Somalia as a research analyst for Forcia Consulting, which is a consultancy based in the US. In 2017, he joined En Ponte Père, INGO, UPP in Syria, as a country director. He was responsible for the emergency and health and protection services in Syria. And then since July 2021, he joined the Relief International, a DC-based INGO, as the Northeast Syria Hub team leader. And since 2020, he also sits as the permanent member in the steering committee of the NES Forum, a coordination platform of all INGOs working in northeast of Syria. Giacomo, the floor is yours.
Hello, everyone. Thank you for being here. So, as our presenter mentioned, fortunately, Northeast Syria is being treated today, just a little bit. And this presentation will be slightly more didactical, let's say, than academic, but I hope it will provide an interesting overview of the situation in NES, and especially of the connection between the humanitarian programming and the early recovery and the long run in general. So please, you can start. Is this one?
Yes, and you can check the screen.
Boom. Okay, so just a little bit of background. The yellow area, it's Northeast Syria, where I have been living in the past 5 years. It's fully accessible for humanitarian stabilization actors and other relief actors. Then you can see from the map below that it's an area that, despite is less populated than certain areas of the Northwest, but the severity of need, and especially health need, has been considered particularly high. A little bit of background. I mean, these are things that have been mentioned today. The conflict obviously had a strong impact on health governance, and that since 10 years basically has been completely unregulated. In 2021, RI conducted a research. It's a qualitative research with semi-structured interview and a desk review of secondary literature. This presentation has also been complemented by the UZ Accountability and Research Team paper that was published last year, and by another paper that MEHAD, together with the Health Working Group and with Primary Care International, has been published a few months ago. The results have been analyzed within the WHO building blocks of healthcare, governance, workforce, quality of service provision, medical products, health information system, and finance that I put in the same slide. So starting with governance, it's quite dense, guys, so apologies for that. We have a multi-layered complex landscape in which we have the Department of Health, that is the central authority, that is the purchaser of services that are delivered by the committees of health at local level. As I was saying, there is a very limited regulatory and planning capacity and no legal framework at the moment. Then we have the Ministry of Health of the government of Syria that is still present in Northeast Syria, but has very, very limited reach and mainly only on vaccinations in government of Syria held pockets in Kamishlo and Hasake. UN agencies, these are UN agencies linked to the country office in Damascus that operate in Northeast Syria, mainly in camps, and that have a lot of access constraints out of camps and that are subject to GOS approvals. Then humanitarian actors and stabilization actors, and where you, unfortunately, there is limited coordinations among these actors and the health authorities. Also, humanitarian and stabilization actors have different programmatic angles, different funding lines, different mandates. So it's very hard to work together in the same direction. And then the private sector, on which we had very low visibility. Now we have a little bit more, thanks to them, but that still it's highly unregulated and where we cannot see a proper connection between the private sector and the public one. However, despite these challenges and this like multifaceted landscape, we have also seen opportunities for ameliorating and strengthening this continuum between humanitarian and recovery. One of them is the definition of a new health law through a committee, a technical advisory committee of NGOs that has been supporting in the definition of it, taking inspiration from the Nigerian health law that has been applied to a federal context and seemed particularly relevant to NES and to Syria at the moment in general. Then we have seen a push from the humanitarian community to strengthen and regulate the services that so far have been delivered more in a response approach without really considering the systemic factors of it. And for this, there has been the establishment of a new working group within the NES Forum that is a sort of OCHA in Northeast Syria to push NGOs and partners to work more in the direction of health system strengthening. And then there is an increased donor interest, we will see it later, in funding this despite all the sensitivities on sovereignty that we have seen in Syria in general and in Northeast because of the issues that we know vis-a-vis also Northwest. And then there is also a push for implementing a long-term capacity strengthening plan for health managers. This is something that at the early stages of the response, we have seen much less than now. Then a few reflections on the workforce. As also Professor Sophie Witter mentioned before, there has been a massive migration also from Northeast Syria that was already more peripheral and rural than the Northwest. So the impact has been even worse, probably, in terms of brain drain. Then we have an unfair competition. This is something that has been mentioned also before by your presentation, between NGOs and the private sector and the public sector. Obviously, the private sector is the one more remunerative. The NGOs in the middle, and the public one is the one that pays the least. So the most capable workers leave the public hospitals and clinics to work elsewhere. Looking at the graph on the top right, you can see that in all Northeast Syria, you don't meet the requirement of 22 health workers for 10,000 population. In the resort, it's even only 2 doctors per 10,000 population. And we have observed a generally inefficient allocation of human resources that does not follow really the logics of what makes sense on the ground according to health regulation, but follows more dynamics that want to meet the needs of local power brokers or tribal dynamics. So it's generally an environment that is extremely dysfunctional and is further complicated by the absence of formal education. There is no formal training system. There is very limited WHO support. In general, there is very limited WHO presence, and the only medical school that is there is not recognized internationally. So anyone that works there then cannot really perform anywhere else. That said, we have tried on the basis of the current environment where we see some glimmers of hope, we have tried to put together some recommendations, like the enlargement of formal education system, supported also by foreign expertise, like Professor Witter mentioned before. There have been recently a study trip to Pisa. I don't know if Dr. Bescher, you were involved in that, but at the Normale University of Pisa, where a few health workers went there and to get trained. Another recommendation is for the Department of Health of the Autonomous Administration to put together a cohort of master trainers to emancipate a little bit the capacity building processes from the NGOs and to move it gradually to the local health authorities. And also there is a push to unify the salary scale. This is one of the greater challenges, I would say, at the moment. And I don't think that NGOs are doing enough in this. Then quality of service provision. First of all, presence of health facilities. From this map, you can see that most of the fully functioning health facilities, according to the HIRAMs, are in the Northwest area. Northeast, there is not even one. Now I think that there are a couple, but as you can see, is extremely underserved. And this may also explain why there is so much access to private services, as the colleague was mentioning before. There are no guidelines and protocols that are officially released by the Autonomous Administration, and there is a sporadic adoption of Government of Syria MOH protocols. Additionally, there is no accountability for malpractice. This is something that obviously affects the trust of the patients in the health system. There are some mitigations measures that have been applied by the NGO community, like humanitarian rehab and stabilization interventions, but that are very targeted and do not have a systemic optic. They are just targeted to service provision in emergency. Then there is INGO's scrutiny and oversight in the projects that are implemented by them on quality of care. There is a sort of ethical mandate from the INGOs to do this, but still it's very localized and it depends on the type of implementation of each actor. Training protocols have been delivered by international actors, and there is that committee of advisory to the DOH that tries to increase the interest of the DOH in building more visibility on the implementation of health programming in NES, but also to increase their ownership in ameliorating the whole system. Ownership, obviously, it's really a key word in this continuum. And a few recommendations also on this. On the one hand, continuing with the rehabilitation of the existing facilities, expanding also other wards, and trying to find a good complementarity between a health, shelter, and WASH actors to make sure that this is done in the most efficient way. Investing in secondary and tertiary care, this is something that I've not mentioned, but in general, the public facilities are primary healthcare, as before the colleague mentioned, so there should be more investment from institutional donors also on secondary and tertiary care. And a very important point is the current development of an essential health service package. It's an initiative of Expertise France that has been particularly successful, that the Department of Health has welcomed. Now it's been reviewed, and there has also been a cost study related to the health service package conducted by a health economist that visited NES recently. Finally, there should be more support for INGOs for the Autonomous Administration to build their own feedback and feedback complaint and response mechanism to enhance the quality and also to improve the trust of the population in in the services. Now, I will go quickly on this, but this is definitely one of the key challenges that we're facing now, especially after the UN resolution that has closed Yarubia border in 2020. There is a continuous chronic shortage of medical supplies and medicines. There are no producers. Generally, the medicines manufactured in Syria are under non-stringent regulatory authority, so NGOs cannot purchase pharmaceuticals in Syria, and this obviously affects also the capacity that the facilities have. Then there are restricted pharma like anesthetics or other type of drugs that cannot be imported by NGOs and that now are not coming anymore through the cross-border resolution through UNFPA, WHO, etc. So this put really at strain the capacity, the health capacity-ness. And there is also low capacity in establishing cold chains for vaccines, for insulin and other pharma that need this kind of preservation. At the same time, we see opportunities because very recently the NGOs came together and conducted the QAMED survey to identify certified suppliers in Syria, and one supplier was identified. This could be a good resource not only for NGOs and stabilization actors in Syria, but at some point even for the Department of Health that has limited resources and that could start to purchase in loco quality medications, not like before. And then there is like another couple of recommendations. One is to properly develop, with the support of INGOs, a system of warehouses with the proper storage protocols, and another recommendation for the NGOs mainly, but also for donors, to keep a solid engagement with KRI authorities, because a lot of the challenges that we have faced to bring timely medical supplies and medical consumables and pharmaceuticals in has been the bureaucracy of Turkey, KRI, and cross-border into NES. NES is particularly inaccessible because there are not certified suppliers in Kurdistan region of Iraq, so you have to go really through a third country. So anything you want to bring into NES, if it's not cross-line from Damascus, which is highly dysfunctional, you have to bring it through Iraq. So there is an additional step. And finally, health information system, as it was mentioned also in the presentation before, at the moment there is no unified health information system. WHO cannot really support on the establishment of this. In terms of surveillance, the e-words and the e-warn system work differently in different areas in a very dysfunctional way. And this obviously has an impact on the decision making, both of the NGOs, but especially of the Department of Health. There are opportunities for changing this, but I expect this to be a very, very long process. There are initial discussions on the unified health information system, where also the King's College of London has participated. And there is an ongoing funding exercise from one institutional donor in Europe to properly map the situation on the ground to a level that is more detailed than the current HIRAMs, and this could also help to identify funding allocation strategies. And on the funding, as I mentioned before, the DOH is only a purchaser of services that has limited oversight on what the committees of health are doing. Also, there is limited complementarity of service between the actors that I've mentioned before, public sector, NGOs, stabilization actors, and private, and there is no visibility on the percentage of budget that these different actors have. So there is an unknown share that obviously impacts the decision making. There are some chances that we see here also in strengthening the financial base, which is an extension of the fiscal base that now is affecting also NGOs. A reinforcement of the finance office of the self-administration in controlling the local committees, trying to contain waste of resources, and the costing exercise that I mentioned before of the essential service package. So what we have seen here is that in general, there is a critical weakness in each of the building blocks that we have mentioned. This is due to instability and political limitations. Right now, for instance, there is an ongoing military operation conducted by the government of Turkey that is impacting any kind of long-term plan. Also, any type of financial allocation that you can actually that the government, sorry, that the DOH can actually implement. And in general, the institutions on the ground are very fragile and dysfunctional. There is limited financial investment, lack of human resources, and market complexities, including the impact that NGOs have, because, as I mentioned, they attract the most skilled people with their salaries. But there is also a key opportunity, especially two key opportunities. One of them is the shift in policy of institutional donors that are looking more into early recovery, that are looking more into health system strengthening and strategies how to implement it, like strategies that they want to devise also to overcome some of the political challenges and sensitivities that are structural to NES. And I can also see in the past 5 years I've been there and I've been exposed to these processes, an interest from many NGOs to gradually transcend the purely humanitarian approach and look into this continuum. I mean, look into funding strategies and criteria that link the meeting short-term needs with what comes in the long run. Obviously, there are still persisting challenges that also affect these opportunities. On the one hand is the weak capacity of the local authorities, but also the still very near-sighted focus of humanitarian NGOs that impacts the gradual handover of responsibilities from humanitarian actors to the public health authorities, and the general political isolation that NES is facing. And then I have one final slide. Sorry, maybe I'm late. I don't want to speak too much about what we do of Relief International, but obviously we are one of the NGOs that tries to look into this connection between humanitarian and long-term the most, involving the local community, trying to keep sustained access in the most underserved area, and looking at long-term capacity building, capacity strengthening plans, because one of the key needs is to rebuild the capacity on. I think before Mr. Ambassador said something very interesting, that you will never recover. I mean, you have to start from something new. And this is the situation where we are, and we have to face this reality and trying to build on the capacity that is there now. And so a couple of key messages: on the one hand, to institutional donors to appreciate this continuum and to between emergency and early recovery, and to adopt suitable funding strategies that look at the short term but also at the long run. Acknowledge the strong need to focus on health system strengthening. At the same time, INGOs should factor the peculiarities of the next context, emergency, but also early recovery, and have to factor sustainable outcomes in their programming, and not just a response to the critical needs on the ground in a specific moment. And recognize the need to achieve efficient complementarity also with the UN actors within and outside camp, and finally highlighting the complexity of needs to the donor community, so that they can have adequate visibility on this complexity and find the tailored solutions.
Thank you very much.
Thank you so much. Sorry, I went a little bit.
It's totally fine, Giacomo. Thank you very much for this very well done presentation that covers a lot of issues of the Northeast. And it's like, for me as a member of the R4HSSS, like a lot of things, I was like, oh my God, I need to talk to you more about a lot of things, so that we can work together on. I don't have a lot of time for a lot of questions, so just one question, and then we'll move to the next presentation. Anyone online? Zahid, I cannot see. Is it all good? Yeah, please go ahead. Yes, of course. Yeah, please. Yeah.
Yeah, actually, we worked a lot with with Giacomo last couple of years. So one last comment also about the challenges in the supply chain. There is a huge challenges about the nutrition supplies, which is, because the cross-border operations are closed, so everything are just going through the cross line, and all the cross-border NGOs, INGOs are not able to get this nutrition supplies. And for those cases for malnutrition, it's reflected on health. I know that our topic is health, but it's reflected on health that a lot of cases are not easily treatable because of these challenges. So this one comment. The second comment is a little bit the way of conducting the projects in NES is different from Northwest, because there is the government, actually the local government there, the local authority. It's not in the Northwest. So this local authority, sometimes NGOs, INGOs had to deal with the local authorities while conducting the activities. I mean, you have to make a contract with the local authority for the facilities, but you are not always conducting the activities by yourself, and this is a little bit affecting the quality sometimes. And because so this is not really the same issue in Northwest. Northwest, you can mainly conduct the activities by yourself, and you can get the highest quality that you want, but
yeah, but you're having parallel systems as well, right?
Yes, actually we have, it's there's disadvantages and advantages.
Of course,
for sure.
yes, of course. I'm so sorry, but we need to move to what do you need?
One very quick question.
Yeah, look at it.
Please. So really interesting presentation, but you mentioned about governance and how NGOs and stabilization actors should work or should collaborate with local health authorities. And how Relief International approaches this matter? Because I know some donors might be resistant to any formal collaborations with local health authorities. But I think the situation in Northeast is, clear that there is one local health authority. I know with different levels of complexity, but how Relief International deals with the situation, and what is the kind of the attitude from your donors?
Yeah. So I cannot reveal all the secrets that we have to go around these sensitivities. But no, I mean, this is a very good point. I mean, and these political sensitivities have been impacting this kind of programming for a very long time. I think now I see a window of opportunity. There are more donors that now I will not mention that are more interested to conduct very under the radar, but projects that entail an involvement of the local authorities, also at planning stage. Then we don't want, for instance, to have financial transfers with local authorities. I mean, there are a few red lines that obviously we have to respect, but when it comes to capacity building, capacity strengthening, involving them in strategic decision-making, first of all, it's essential, I mean, if we want to deliver meaningful services to the population. And secondly, it also allows you to go around these sensitivities a little bit. Then I don't want to enter too much into the technical details, but there is a window of opportunity that before was less there.
I was planning to ask him these things on the lunch break, He wouldn't say these things like on the mic, the political sensitivities. Thank you very much, Giacomo. And now we'll go to the next presentation, which is focusing on revealing the significant shortcomings in the learning environment in the 3 largest medical schools in Syria. What's next? It's going to be presented by Ghaith Alfakhry. He's a researcher in medical education at Al-Sharm Private University. He graduated from Damascus University Faculty of Dental Medicine in 2020 and currently completing a Master's of Medical Education at the Syrian Virtual University. Ghaith, are you with us?
Yeah, sure. I'm here.
Yeah, please, Ghaith. So please, the floor is yours.
Yeah, sure. Just let me share my screen.
Of course, yeah. Yeah, so we can see the screen, Ghaith. You can start whenever you want.
Yeah. Now, my subject is a little bit different than what the major conference fellows here talking about. It's more about the medical education system, which I believe is what the public health sector hinges on, because what capacity building means is really hinges on the quality of health providers, which are medical students and those who will become the future, let's say, health providers. So here I'm going to talk about what is education like in the Syrian universities, mainly in regime controlled areas. So this is the table of content. It follows the same, structure of a research paper, just like background, methods, discussion, and ending with conclusion. Now, I'm going to discuss discuss briefly the concepts of this research. Now, what is a learning environment? According to the Macy's Foundation, the learning environment is defined as the social interaction, the organizational cultures and structures and physical and virtual spaces that surround and shape participants' experiences, perceptions, and learning. Now, this might be a little bit different in medical education. In medical education, learning environment has been subconceptualized to 5 main domains, which are the teaching quality, teachers' characteristics, the career achievement and approaches to learning, the school atmosphere, and the personal life and the social atmosphere itself. Now, what is the medical education system like in Syria? Now, the medical education system in Syria has been following the same formula for decades now. It's traditional, teacher-centered. It depends on information gathering approaches. It has a fragmented curriculum. There is no integration between preclinical basic sciences and like clinical aspects of the, let's say, education. It depends on large group teaching, lectures, and the exams are mainly paper-based exams following MCQs. Now, aim of this study aimed to conduct the first large-scale evaluation of the learning environment at medical schools in Syria, to highlight its areas of improvement and to suggest to make suggestions that address these issues effectively. Now, the methods. This is a cross-sectional questionnaire survey study conducted in 2022. The participants, now I'm going to explain briefly what is medical education is like in Syria. Now, it's consisted of 6 years, one preparatory year, 2 preclinical years, and 3 clinical years. So it's different like from other countries, just like UK and USA, which follow like 2 years of, pre-medical school, then 4 years medical school, then, residency stuff. So we have 5 major universities in Syria, public universities in Syria. This has been supplemented by 2 new universities, Al-Hama and Tartus University in 2014, due to the major flow of students to, most stable universities such as Tishrin and Damascus University. Our study covered 3 main universities, which are Damascus University, Tishrin University, and Aleppo University. So we use non-probability sampling, such as both paper-based and online surveys. We use snowball sampling, convenience sampling, and as well as reverse sampling utilizing social media platforms such as Facebook, Telegram, and WhatsApp. Now, our data collection instrument was the DREAM questionnaire. It's a validated instrument designed to evaluate the learning environment at medical schools. It's generic and it's available in different languages, including Arabic. Now, the DREAM's inventory consisted of 50 items and 5 domains. The responses are recorded on a 5-point Likert scale from strongly disagree to strongly agree. Now, the domains of the DREAM questionnaire are, divided to 5 domains, just like as we talked about before. So here we have the student perception of learning, student perception of teachers, academic self-perception, the perception of the atmosphere, and the social self-perception. So there is also an interpretation guide for the DREAM, actually. So the DREAM questionnaire is graded on a 200 points. So at the end, the student completes the questionnaire. We have like 200 points. If the student scored like, let's say 25, that means the learning environment is perceived very poorly. Like if it was like scored 99, like there are plenty of problems, so on and so forth. Now, there are some negatively phrased items. Of course, we've done reverse coding for these so that, the higher the score, the more positive the result is. Now, the data collection process started in April 2022 and ended in July 2022. It's like 3 months data collection period. The statistical analysis, we used Chromebox Alpha to measure the internal consistency. We used Mann-Whitney U-test because the superior wealth statistics was significant. Nevertheless, we used one-way ANOVA because one-way ANOVA is robust even if the data was not normally distributed, if the sample size is larger than 30 and if the normal distribution is not very severely skewed. We used Games Howl because normal Levine normality test was significant. Now, we adopted a reduced p-value of 0.01, less than 0.01, like to countermeasure the risk of mass significance when comparing three groups. In all other cases, a p-value less than 0.05 was adopted. Now, let's talk about the results. 1,774 participants were recruited in the study. The Cronbach's alpha's value for the 50 statements was very high. It was 0.92, which indicates a very good internal consistency of the instrument. Now, these are the demographics of the study. We had like a little bit over 900 at Damascus University, over 500 at Aleppo University, and 300 at Tishrin University. Now, as for the female-male distribution, we had like almost 50-50%, which is great. As for the age mean, it was about, the total one was 22 plus minus 1.8 standard deviation. Now, let's talk about the results. Here, this table presents the results according to the domain as well as the dream, the max, the total dream score. We can see here, everything is in red, has a negative interpretation of the environment. For example, here, then learning is perceived negatively, as well as the academic self-perception, as well as the atmosphere. And the dream total score is lower than the cutoff point, which is 101. Now, Aleppo University is like measurably the same. It differs in the total dream score, which is like a little bit higher, 101.3. Tishrin University scored the lowest, scored 97.8, plus minus 35.7 standard deviation. Like, as we can see here, the scores across universities were very similar. We can see here the one-way ANOVA shows like there is no significant difference. As we can remember, like the significant difference cutoff point is less than 0.01. So here there is no significant difference between universities except for the teachers domain, the perception of teachers. Here we can see that students at Damascus University perceive their teachers more positively than the other universities. And nevertheless, the effect size was small, was very small. Now, here we're going to see the dream score according to the year of study. Like here we have year 2, year 3, year 4 to year 6. More junior students perceive the learning environment more positively than their senior counterparts. We can see here like it drops to 96.5 and 94.8 in like year 6, year 4 respectively. As for the stage, we have like preclinical and clinical students. We can see obviously that the clinical students had a much lower score. It's like 95.6 out of 200. There's a significant difference, like less than 0.001 in the overall scale and across all subscales. As for the sex, like males scored significantly less than females, particularly in the perception of teaching and perception of atmosphere. Now, here we have the participants' responses at the item level. Now, I just wanted to remind you that the scale is out of 4, like it is 5-point scale. So 0 indicates a very negative interpretation and 4 has a very positive interpretation. Now, students' perception of learning. Here we can see that students do not agree that the teaching is student-centered. It's less than 2. So, and they do not agree that the teaching develops their competence, nor develops their confidence. And actually teaching emphasizes factual learning. And it does not encourage active learning. Now, the teachers are perceived as authoritarian, but there is the teachers provide constructive criticism. Equal portion of students agreed and disagreed regarding this. However, at Tishrin University, the mean was 1.8, which is lower than the cutoff point, which is 2. Now here we have the students' academic self-perception. We can see here that students do not feel they are being prepared well for their profession, and they do not believe that the last year's work was a good preparation for this year's work. They're not able to memorize everything they need, and equal proportion of students do not believe that they are being prepared, what they're learning is relevant to their career in healthcare. As for the perception of atmosphere, as you can see here, students do not believe that the atmosphere is relaxed during clinical teaching. They do not believe that school is well timetabled. As for cheating is a problem in the school, Tishrin University, like a significant number of students think that cheating is a problem in the school. The enjoyment does not outweigh the stress of the course, and the atmosphere does not motivate them, motivate the participants to be as a learner. Now, students' social self-perception is actually the lowest scoring subscale. So there isn't a good support system for students who are stressed. Students are too tired to enjoy the course. They're bored, and the accommodation is not pleasant. Now, let's put the findings into context. This study aimed to provide the first evaluation of the learning environment at medical schools in Syria. So, using the interpretation of DREAM, the total score falls in the plenty of problem scale, although it's at the very end. But nonetheless, it falls in this means that the learning environment has plenty of problems. At the domain level, we can see here that teaching is viewed negatively. Academic self-perception has many negative aspects. The atmosphere has many issues, and the social self-perception indicates that the universities are not a nice place. The lowest scoring domains are learning. Teaching is viewed negatively. It scored like 45% of the total score, and the social self-perception, which scored like 43.5%. Now, according to a systematic review published in 2018 of studies that use the DREAM scale, over 80% of studies, over 80% of 98 studies reported a score in the negative range, like between 101 and 150 range. I'm going to display some of their studies. For example, here we have a study in the UK that most studies in the UK using the DREAM scale recorded scores like above 140. I believe this score like 155 out of 200. This indicates like the learning environment is excellent. Actually, this score belongs to King's College London. Australia as well records like very high scores. Nevertheless, like we have UAE, Iran, Saudi Arabia, they scored variously because like different schools have different scoring of the learning environment, and they range from, more positive than negative to plenty of problems. In Syria, we can see here that the scores are consistent. They are very similar to one another. Now, here we're going to explore the factors that associate what is a low DREAM score associated with. Usually, literature tells us that the low DREAM score is associated with traditional discipline-based curriculum, lecture-based, teacher-centered approaches, as well as psychological distress and lack of social support, whereas high DREAM scores usually is associated with integrated curriculum, student-centered approaches, small learning groups, good infrastructure of the school, as well as a higher quality of life. Now, we're going to connect the phenomenon to the context more here. The Syrian conflict could be a contributing factor to the negative learning environment. As you might know, like there are major internal and external displacement. There is a decreasing quality of life, like especially now in the collapsing economy. There are physical, psychological, and social trauma, as well as the international sanctions that debilitated the economy. Now, there is an increasing medical students intake, nevertheless, at public schools. Nevertheless, this increase in the medical students intake is not accompanied with an increase in teaching capacity. On the contrary, actually, the teaching capacity is decreasing due to the immigration of the teaching staff. Now, what are the implications of a negative learning environment?
Ghaith, 3 more minutes, okay?
Okay, we're going to finish real quick. Yeah. Now, implications of a negative learning environment are threefold. Educationally, skills and knowledge attainment might be negatively affected of students. Professionally, students might develop unsympathetic attitude towards patients. There might be like lower performance standards and lower treatment quality. Personally, it could affect students' character development as well as psychosocial well-being. Now, the negative learning environment could also be a predisposing factor for medical students' workforce mass exodus from Syria, which leads to a shortage of specialized medical workforce in Syria. Now, according to a study in 2018, over 78% of medical students in Syria want to specialize abroad. Now, this leads to a vicious cycle because, like, the medical workforce exodus leads to a deterioration of the healthcare sector, which incentivizes the Ministry of Higher Education to increase the medical students' intake. However, if this increasing intake is not accompanied by an increase in teaching capacity, there will be lower teaching standards, and this will lead to a deterioration of the learning environment, which might be a contributing factor to the medical workforce exodus. This is like a vicious cycle. So we're gonna skip a few slides just because, like, now what's next? We need a curriculum reform. A curriculum reform needs two main things: a cohort of competent education experts, which we unfortunately lack, but most importantly, a facilitating institutional framework. There has been an attempt to reform the curriculum at Damascus University in between 2006 and 2011, run by WHO, British Council, and Damascus University. Nevertheless, this attempt failed and stopped in 2011 because of the Syrian conflict. The study that emerged from this attempt talked about the problematic institutional policies. Now, because they hinder the development of the curriculum. Now, institutional policies are very hard to change because they are tied to university governance, which are tied to national law. National law is very hard to change and requires upper governmental approval. Now, we're gonna skip a little bit. Contribution of this paper. This study provides a baseline reading and a diagnostic analysis of the learning environment at medical schools in Syria. I'm happy to say that, like, the study has been recently accepted for publication by BMC Medical Education and will be made available online soon, as well as with the data. Like, thank you for listening. If you have any queries, please, I'm all ears.
Thank you. Thank you very much, Ghaith. Thank you. That was very, very interesting. Ghaith, I want to ask you, were there similar studies done before the conflict?
Actually, no.
No.
The medical education sector here in Syria is very underdeveloped.
Okay, because again, Syria before the conflict, it was one of the major hubs for medical tourism. And so a lot of people from the Middle East would go to Syria to seek healthcare because it was cheap with a very good quality. So I'm a bit surprised. So I was just wondering whether there were any changes because of the conflict or whether the curriculum itself was, again, medical students were struggling while they were at the university, but then they were flourished once they graduate.
Actually, there has been a study about this. There has been a study that, studied the increasing number of medical students and the prevalence of disease in Syria. There hasn't been found like a decrease in the prevalence of disease despite the enormous increase in the number of medical students. This one of the implications of the study that medical students are not able to, let's say, handle or shoulder the health demands of the population. Now, we have some outstanding physicians, but these are these are individuals. They are not like a whole system. They're not the health system. Like, we have like amazing physicians, but unfortunately they are individuals. They are not as you
they are
might
students.
know. Exactly.
They are students. Yeah.
Exactly.
Students complain.
Exactly.
Anyways, I'm so sorry. I need to move to the next presentation so that then we can have our lunch break. Thank you very much, Ghaith. That was very interesting. And then we'll move to the next one. Our presenter is Bahauddin Haffar. He's going to be talking about the public health consequences after 10 years of the Syrian crisis literature review. Baha is a dental surgeon, graduated from the Damascus University and completed a master's degree in public health at the Bursa University in Hungary. I hope that I spelled it right. He is currently working as a researcher at the Department of Public Health in Disaster at Karolinska Institute in Sweden. He published over 20 original articles focusing on Syrian crisis, Syrian health systems, and refugees. And here we go. Yes, Baha, are you with us?
Yes, yes. Hello, everyone.
Please,
I hope.
go ahead. The floor is yours.
Thank you very much. So I assume you hear me well. I will just jump into the presentation. Thank you very much for the introduction. It's always a pleasure to be here. I've been following this conference for all through all the years. It's my second time. So my name is Baha. I'm a researcher at the Department of Public Health and Disaster in Sweden, in Karolinska Institute. Today, I'm going to present the public health consequences after a decade of war in Syria. So let's jump into it. So just a quick introduction, the last humanitarian need assessment published by OCHA on the Relief web, like shocking numbers, over 14.6 million of people in need, and the majority of these people are in need for health services. Unfortunately, this overview or this article doesn't specify what's the need and how do we approach them. And this was the main question I tried to answer in my research. Of course, this research was before the latest publication from the OCHA. So I asked myself, is there one report I can read and I get all the information about the health cluster and the changes that happened during the last decade in Syria? And unfortunately, there wasn't. I mean, is there one report that gather all the information in all the health sector? No. So that's what I tried to answer. I did this literature review, gathered all the literature published over the concerning the health sector with one study over the Syrian population, and of course analyzed this articles to provide what is the current health status, what's the health problems, and how we can move forward, what's the gaps we can address and move to the future health system in Syria. Yes, so we had many objectives, such as summarize all this article in one publication, describe what is the public health consequences of the Syrian war, what is the gaps that we can address of the Syrian population, and suggest strategies that go hand by hand with the WHO health system building blocks to rebuild the Syrian health system. So the methodology was clear. I'm just gonna describe a little bit about the articles. There was over 13,000 articles mentioned Syria or Syrian or war or crisis according to this research strategy. When we applied our inclusion criteria, we excluded all the articles that are not like concerning the Syrian war and not the Syrian population. We end up with 440 articles. All these articles were included into one database, were analyzed, were divided into categories, were divided into 10 categories, and a big team read this article and summarize the information, but where's the gaps, what we know, what we don't know, what's the latest statistics, what's the topics we don't have statistics about. So briefly, we had over 9 topic articles concerning health system, the population, the occupational health, also oral health. There's some publication about this, non-communicable disease, infectious diseases, a lot of topics. So in this article, we can read about all the health aspects and understand what's happened during the Syrian crisis, during the years, during the changes, and also we can see the gaps. And now I'm going to give you only the most important results, because of course I can't talk about all of these results I found. It's a very, very big literature review. One very interesting result is that about the health infrastructure. What we have is around 50% only of the health facilities are functioning, but 23% are partially functioning and 26% are not functioning. This has, of course, increased the pressure of the functioning health facilities. Also, as mentioned before, over 70% of the health force fled outside of the country. And this is also all recent result. In this map, we can see all the functioning and non-functioning health facilities, all provided by HERMAS, which is supported by WHO. Another interesting result is that we can't talk now about the Syrian population as like a general word. We have to specify the population living in Turkey and their access to health services in Lebanon, in Jordan, in Europe, and also the people living in north or east of Syria, and in the area governmental controlled. Everyone has different access to health services. Every population has different need and different gaps. All of these are addressed in this literature review. For example, we can't discuss Northeast Syria without talking about like direct hits for the health facilities as a consequences of the war, whereas these are not applicable in different areas. Also, in governmental control, we can't talk about the Syrian population living there without talking about the lack of the health services, the lack of the medical equipment, and all of these gaps. As I said, the results are really big. So now I'm just going briefly to give you a hint about the result I described in this literature review. Also, about infectious disease, this is very important. We know since the beginning of the crisis, the vaccinations program has stopped or at least interrupted in big areas of Syria. There was an outbreaks of many infectious and treatable disease. We thought we eradicated before, but they came back again, such as tuberculosis, leishmaniasis, and polio. And recently, of course, we're all following what's happening with the outbreak of cholera. This is all described, and it's like the problem is the early warning system we have, whether we're talking about the early warning system led by WHO in the governmental controlled area in Syria, or the early warning system in the northeast of Syria, are both not fully functioning. They have delay and under-reporting of cases. The delay can sometimes reach of 15 days to 20 days. And of course, when we're talking about an outbreak, 15 days can matter a lot in the first initial response and in controlling this outbreak. So this is one of the major problems. I'm sorry for this slide. I know it's a lot of information, but don't worry, I'm not gonna read or I'm not gonna present it all. I'm just gonna tell some hints, for example, about the maternal and the children health. We have a problem that over 80% of pregnant women didn't have any single visit for maternal care during or after their giving birth. That's shocking numbers. And the problem, there's some gap in research that we don't have updated information, and there's not enough attention on this. Also, mental health, it's one of the biggest issues. We have increased levels of PTSD, depression, panic attack. This also affecting the health workers. And also one of the gaps is that there is no report evaluating the interventions in the mental health. Also, we discussed about the oral health, we discussed about the non-communicable diseases, which is also, there's no updated information. Like we have a lot of advanced research, some really impressive research happening and published from Syria, but we don't have updated numbers about the simple thing, like what's the percentage of the cardiovascular diseases? Why a lot of young people are dying of the cardiovascular diseases, the chronic respiratory diseases? These are areas of gaps we need to address in the future research. And final thing, we talk about the occupational health, which is concerning the healthcare workers in Syria, the level of depression, the level of psychological distress they have, and also we talked about the gaps in this area. Moving on, also, the final part of my research, I discussed what's the future plan if we want to build the Syrian health system in general. Of course, I adopted most of the ideas from the WHO building blocks. I'm really impressive of the research also Mr. Paladin has been presenting previously. It's really impressive, but I did some changes and I did some suggestions how we're gonna reestablish the Syrian health system by first preparation of the health infrastructure, increasing the capacity, whether it's the health worker capacity or the health facility capacity, and improving the health, improving the human resources we have and the medical doctors, the training of them, because it's also the training it's a little bit questioned now from the governmental university, from private universities, and I think Dr. Ghaith just introduced a lot of information about this. More step is to support the medical research in the health facilities and the health informatics. It's also described how we're gonna build a health database and how we make a decision built on evidence regarding the health sector. There's other publication I published in this area, and I had some primary data. It's not all literature review. I had some primary data incorporated in this research, and that's what give it a little bit of dynamic. So we're not only describing other articles, we had primary data, and we described this inside the literature review. So as I said before, it's a literature review with a lot of results. I just give the hints, the primary hints about the most significant results, but I can't go deep because I think the organizer of the conference will just kick me out. I have a lot of results. So now we're just reaching the conclusion. We know that there's a direct and indirect hit of the Syrian health system. In this article, we described the public health consequences of this war and how we can what's the gaps we have in the health system and how we can overcome these gaps and rebuild the Syrian health system in like advanced way based on evidence, based on what the World Health Organization suggests. If you want to read more, it's published in Globalization and Health. It's of course a BMC journal. It has a high impact factor, and currently now I've seen a lot of interesting projects. So I would like also to say that currently I'm working on the assessment of the health system capacity for crisis management. So if anyone interested, we can also work. We have some cooperation and also on cholera response. Finally, I would like to say acknowledgement for Professor Shander Janusz for his support for this research in Debrecen University. Of course, for the Department of Global Health in Karolinska Institute, they always support research concerning the Syrian crisis, and for all the organizers of this conference. And thank you very much. If there's any question, please, I'm all ears.
Baha, thank you. Thank you very much for this nice presentation and this very interesting literature review. And it's very impressive that you mentioned like Syria in overall, like Syria, not Northwest or Northeast or the areas which are like government, under the government, Assad regime's control. Do we have any questions from those online or here in the room? So I'm going to ask you that. So again, I haven't gone over the literature review, to be honest. I think I just read the abstract at some point. Something that is put on my to-do list, the long one. But my question is that for you is that, have you done any kind of analysis based on regions, like regional needs, if they are different? Anything regarding this aspect that you can elaborate about more about?
Yeah. Actually, as you said, it's because in different regions, there's different needs. So part of the analysis is about different regions. But honestly, basically, it was politically divided. So we have the north and northeast of Syria, and we have the area of which is under the governmental control. So the analysis was based on this. I mean, I can elaborate more if there's time. For example, the northeast of Syria, we have the most of the outbreak of the infectious disease. We have the most of lack of access to health services. But on the other hand, we have the assistant of a humanitarian organization, which have access to this area, not the same we can see in other regions of Syria. That's one of the most interesting points I have. So I hope I answered your question.
Yeah, you did actually, and thank you very much. I would have elaborated more, but apparently we are a bit late for lunch, and so thank you very much, Baha, again for this very interesting presentation. And now we're going to have a 45-minute lunch break, and then we will go back for the third session for today. Thanks again, everyone. Thank you, Baha, and also all of the previous speakers. You were amazing. This is a very interesting conference, and we will be back in 45 minutes. And for the people here, bon appetit. Enjoy your mini lunch. Yeah.
in 2 minutes. So if you want to just get back. Okay, I think we can get started. So I hope you enjoyed your lunch. And the next session will be talking about health interventions and the focus on morbidities during conflict. So kind of shifting from the bigger picture now into more disease-specific focus. Our first presenter is Mariam Ahmed. Mariam is a medical student at Imperial College, London, who completed her intercalated BSc in global health. During her BSc, she developed an interest in the impact of the Syrian conflict on healthcare, particularly in Northwest Syria. This led her to her dissertation with the Syrian American Medical Society on the impact of conflict and the impact the conflict has had on non-communicable diseases. Please welcome her presenting her research on service utilization trends during conflict with a focus on NCDs in Northwest Syria. Over to you, Mariam.
Thank you very much. I'm honored to be here on behalf of the Syrian American Medical Society to talk about healthcare utilization in Northwest Syria. So to start off with, our aims were to analyze healthcare utilization and in particular how conflict events have impacted on healthcare utilization. We also focused on non-communicable diseases and we used forced displacement as a surrogate for instability to look at how forced displacement affected healthcare as well. So some background, we looked at Northwest Syria in particular because of course it's the last remaining area of non-governmental control, and so it's in particular susceptible to the effects of conflict, but also because SAM's facilities are mainly based in Northwest Syria, and it makes up about 20% on average of the healthcare coverage. Also, the area has been in particularly affected by the UN Security Council vote on cross-border aid. This is important because border crossings are areas for trade to occur and for aid to enter Syria. Previously, there were 4 border crossings, but now only Bab al-Hawa, which is in Northwest Syria, is open, but it's constantly under the threat of closure. And we focused on non-communicable diseases as well because the burden of non-communicable diseases has increased. However, there hasn't been the necessary services to deal with that increase in non-communicable diseases. And we know that non-communicable diseases need early recognition and prevention and regular management. And of course, it's an important area to look at. And we know that in Northwest Syria is home to over 4.5 million people. 50% of those are internally displaced persons. Of that 50%, 80% of those are also women and children. So forced displacement is particularly of interest when talking about Northwest Syria. And over the course of our 3-year study, which was between January 2019 and December 2021, there were 2 waves of forced displacement. So one between May and June of 2019, and the second larger wave, which affected 450,000 people between December 2019 and February 2020. And this is the area we were looking at. So in terms of our methods, this was a retrospective quantitative analysis. The data was collected by SAM's field teams in Northwest Syria. It was then uploaded onto the DHIS system using ICD-10 coding, and we used UN OCHA data on forced displacement. There were no exclusion criteria. We included everybody who presented to SAM's facilities in Northwest Syria. However, for the non-communicable disease data, we included over 18s only because we wanted to focus on the adult population. The data was then aggregated, analyzed, we made graphical representations, and we calculated the percentage change of the temporal data. So looking at 2019 and comparing it to 2020, looking at 2020 and comparing it to 2021. And then we also looked at the percentage change between critical periods, so before and after a wave of mass displacement, for example. And then we used a two-tailed t-test to test for any statistical significance. In terms of ethics, everything was analyzed independently of data collection to avoid bias. The facilities names were anonymized. Everything was password protected and stored securely for data protection. This is a map of the SAM's facilities in Northwest Syria. In red, you can see the primary care facilities, and in blue are the secondary care facilities. We looked at 33 facilities. Over 3.6 million consultations were analyzed, which amounts to roughly 6,500 consultations per facility per month. So this is a graph showing the total consultations over time. In red, you can see the consultations, and in blue, the number of facilities that were open. I just want to sort of draw your attention here to this period, January 2019 until March 2020. This period here was fairly stable. There wasn't too much increase in consultations. However, after March of 2020, there's this massive increase here in consultations. So what happened in March of 2020? In March of 2020, there was, in March of 2020, there was a ceasefire that was brokered between the Russian and Turkish forces over Idlib, which was largely upheld. So there's an association that after this ceasefire, there was an increase in consultations. And this could be due to an improvement in healthcare access due to reduced conflict. Also, on this graph, we can see two peaks which occurred around the time of the border crossing, votes for border crossing closures. And so this is potentially due to an increase of healthcare use in anticipation of the border crossing closures, where there might be reduced aid entering after the closures. So this shows non-communicable disease data in terms of consultations in which a non-communicable disease was a noted comorbidity. Again, what you can see here, so in blue is the diabetes, and in red is hypertension, in green is cardiovascular disease, and in darker colors you can see primary care, and in lighter colors you can see secondary care facilities. And just so over here, again, before March of 2020, there was no statistically significant increase in consultations. However, after March of 2020, there's a huge increase in only primary care facilities, mainly in primary care facilities. And this, in March of 2020, there was also a PEN protocol which was introduced by SAMS. The PEN protocol was initially a WHO initiative. SAMS then sort of adapted it and applied it to Northwest Syria. And it involved two main areas of focus. The first was an educational initiative involving healthcare professionals, educating them about the diagnosis, management, and treatment of non-communicable diseases. But the second part was a protocol that was around how to convert existing facilities that were already up and running into non-communicable disease services as well, to accommodate non-communicable disease. And that, as you can see, was only implemented in primary care facilities, and that's why we see mainly an increase in primary care facilities. And this graph shows some trends in forced displacement. So in red, you can see the youngest age group, 0 to 18, and the number of consultations for that age group. And then in yellow, you have the 19 to 49 age group, and then 50 plus in green. And in blue, you can see displacement trends. So you have your first wave of displacement here, and the second wave of displacement, which was a larger wave between November and March 2020. And what's interesting here is there's initially, during displacement, there's a dip in consultations, mainly seen in the younger age group, for both displacement waves. However, yeah, so we think this potentially could be due to people not being able to access healthcare. Obviously, they're more concerned with getting to safety during waves of forced displacement. However, after displacement waves have finished, there's this increase in consultations or a peak in consultations because people now have the ability to access healthcare a bit more. And similar patterns were seen during COVID-19 waves globally, where initially there was a decrease during a wave of COVID-19 in consultations. And then afterwards, after the COVID wave had gone down a bit, there was a peak in consultations due to a backlog of people who hadn't been able to access healthcare. So some of the key points, the threat of a border crossing closure may have impacted healthcare utilization. There's this apparent increase in primary care consultations after March 2020 when the PEN protocol was implemented. And there's a massive forced displacement which may have affected healthcare utilization. Some of the strengths of this study, it was a particularly large data set of 3.6 million consultations, so largely can be generalized to Northwest Syria, the population in Northwest Syria. Also, the research was led by the SAMS research team, in particular Dr. Aula Abara, who works for Imperial College and also works as the SAMS research manager, and Dr. Mohammed Hamza, who's the SAMS research manager. So I'm not from Syria. I have a limited experiential knowledge of the situation in Syria, and so they provided a more contextualized analysis of the data. And also the time period we looked at was a period of active conflict between 2019 to 2021, which was interesting to be able to assess the impact of those conflict events, border crossing closures, and the impact of forced displacement. However, I think because it was a period of active conflict, there may have been a potential for underreporting within the data set. Also, there's a potential reporting bias around non-communicable disease data. How do you know that it was a genuine increase in non-communicable disease care versus an increase in educational awareness of the doctors who then started reporting more non-communicable disease consultations? And also we included only 3 non-communicable diseases, mainly because these were the most robust within the data set, and we also felt that we wanted to go into more depth with our analysis. So how can this be used in the future? I think we highlighted the potential effect of conflict events, and we hope that humanitarian organizations can use this data to potentially help mitigate the effects of conflict events in their future plannings. And also due to the success of the PEN protocol, which was observed in this study, the PEN protocol has now been expanded further in Syria. Yeah, thank you very much for listening.
Thank you so much, Mariam. Thank you. Just a quick, first of all, thank you so much for providing. I think it's really nice to see studies focusing on health issues, but also taking into account the overall kind of context and the political events that took place. I'm personally sometimes frustrated by looking at papers that really don't take any of that into account. And I think it's really important to view it with that holistic lens. So thank you for that. I'll open the floors to any kind of questions. I think also from the online. We've got questions online. Okay, so maybe we can start with those.
Well, may I ask? My name is Fuad.
Please go ahead.
Thank you very much. Mariam, thank you very much for your presentation. This is definitely interesting. And the main issue, I mean, I agree with you, the strength of this is the number with this millions of consultation. So just a clarification, if you can, so it's consultation and not patient, right? The second issue is I think there is a sort of missing opportunities. You know, usually when thinking about NCDs, I mean, it's very sort of normal to look for the most robust, you know, NCDs, I mean, hypertension, diabetes. But with this huge number of consultations, I think it could be something very important to look to some cases that are more complicated, given the chronicity of the crisis now in Northwest Syria. I mean, cancer, for example, or, you know, renal disorders that could give a sort of to shed light on these two expensive and more complicated diseases. So so that's my comment, and a tiny question about the consultation versus patient. Thank you.
Thank you. Yeah, I do take your point. It's very important to focus on the wider context of non-communicable diseases and in particular, you know, cancer and look at all non-communicable diseases. And I think we chose those three in particular because within the data set, they were the most prevalent, the most robust. And of course, in the pipelines, we have more non-communicable disease as well. I didn't quite catch the first part.
It was also a question I had. So about consultations versus new consultations. I think, correct me if I'm misunderstanding your questions, but this idea of a patient versus consultation. So is it kind of the same people visiting over and over again, or are we also accessing communities that maybe are not reaching, you know?
Of course, yeah. So so I mentioned in the presentation there's 3.6 million consultations. Of course, that doesn't equate to patients. So it could be people visiting over and over again. It could be the same patients. However, I think because the research was quite vast in terms of the number of facilities and the spread of data, and so, yeah, I agree. It is consultations, not patients.
Perfect.
Yeah.
Thank you for clarifying that. So any questions from the audience here today as well? Yeah, Giulia?
Thanks so much for very, very interesting package.
We can't hear the question.
Yeah, sorry. I think they're passing a mic over to you right now.
Just a comment about the implementation of the PEN would be interesting to actually follow up maybe with further research about the actual implementation and the bottlenecks eventually. It was just a comment. Regarding the graphs and showing the total number of consultations, I'm not sure if I'm understanding it correctly, but it seems that the consultations for the age group between 0 and 18 was the higher?
Yeah, oh, sorry, I forgot to mention that. But yeah, the most consultations were in the youngest age group for total consultations. So the children 0 to 18 age group had the highest level of consultations. But we didn't look at the age breakdown for non-communicable diseases. So that wouldn't include children.
So that's not for non-communicable diseases.
No,
no.
no.
Wondering if, and you look at type 1 and 2 diabetes or just type 2 diabetes?
Sorry, repeat that.
You look only to type 2 diabetes or both type 1?
So we looked at both types, so all presentations of diabetes together, but I think that's partly the reason why we excluded the under 18 age group, because we wanted to focus on chronic, diseases such as type 2 diabetes, cardiovascular disease, and particularly in the older population. Yeah. Thank you.
Thank you. I think there was another question, so I think Priti wanted to. Yeah.
Thank you. That's super interesting. Did you disaggregate the data by gender? And also, do you have some plans for like a follow-up qualitative study on, so who's not coming for consultations when they have NCDs? Are you getting a representative sample or people coming from displaced communities? Do you report displacement? And do you look at any kind of correlation between patterns of displacement and then disaggregate by gender, seeing just interested to know whether women are coming forward to the NCD consultations at all.
So I think, sorry, I'll just repeat that question because I'm not sure it was heard online. So the question was about disaggregation by gender and also whether it might be useful to add the qualitative component as well. Okay.
Just to mention that Mohammed Hamza is online, so he will contribute if you would like him to.
Oh, brilliant. Yeah, I'll ask for his opinion as well in a bit on some of the questions. But that was a very good question, because I also wanted to look at a bit of the demographic breakdowns. And I did look at, it was too much, I had a lot of graphs, too much to put in this presentation, but some of it was looking at, different age groups, different primary care presentations versus secondary care presentations. They all followed, all different age groups, different genders followed the same sort of patterns of increase and peaks. However, young age groups presented more. I think women presented more as well. And we didn't, unfortunately, within this study look at, a more qualitative aspect, but something we can certainly look into for the future. Thank you. Mohammed Hamza, I don't know if you're there and if you want to add anything.
Good morning, good afternoon for you all, and thank you, Mariam, for the presentation. Yes, I mean, just quick comments regarding some of the questions that has been raised by the colleagues. As you can notice, there are so many aspects that we could be discussing and exploring about the status of NCD care in Northwest Syria and Syria in general, because of the scarcity of available information. What we are trying to do is at least to package it into a smaller papers where we will be able to bring some clarity about some of the aspects, but aspects related to disaggregation by gender is something that we will be working on. There are, as Mariam has mentioned, already papers expected to be published soon discussing the cancer care in Northwest Syria as part of the NCD. I know that Health Cluster as well is working about an evaluation for chronic renal diseases care in Northwest Syria. I mean, there are so many aspects, but honestly, what was very interesting to discuss maybe at this time of the year when we have the continuous debate about the importance of humanitarian access is to show how sensitive humanitarian and medical care is influenced by political decisions, and how eventually, I mean, even the psychic of the patients could be very affected whenever there is fear of potential closure of border crossing and the provision of medications to the population. Just also wanted to quickly comment on this debate and say that usually whenever we would have a potential non-renewal of the cross-border resolution, we would see an increased positioning of medications from humanitarian agencies in anticipation for a potential potential contingency planning. This would reflect sometimes when we know that the resolution is renewed, at least for additional months, by an increased prescriptions in the facilities for the medication. Because in our best cases, sometimes we always have about 70% coverage of medication for NCD. So we always have a less percentage of people who are covered. There is an absorption capacity that is not 100% addressed. And this is also to show the importance of, the underservice of NCD care in this conflict after 10 years. So these are some ideas. Future studies about, let's say, unique patients and not consultations is something that we will be very able to do so thanks to an introduction of health information, medical records in our facilities, and hopefully we will be able to do that in the future.
Thank you so much. Thank you again, Mariam and Mohammed, for the really interesting presentation. So with that, we'll be moving to our second presentation. So our second speaker will be joining us online. So Dr. Mohammed Abu Hilal, who's a Syrian psychiatrist and MHPSS trainer. He has 11 years of experience in the Syrian context, and he will be presenting his research on demographics and risk factors for suicide in the Syrian context, specifically a retrospective online analysis of news, so content analysis. Dr. Mohammed, over to you.
Assalamu alaikum. You hear me?
Yep.
Yeah, thank you for this opportunity to present our work. And I wished I was physically present, but unfortunately for visa issues, I was not able actually to be physical. So I will present now online. Yes, so I will be just sharing my screen. Do you see my screen?
We do now, yes.
So our research will be about the demographics and risk factors for suicide in Syria, a retrospective analysis of online news content. So as we heard recently, suicide news has dominated, and a lot of cases was reported. And there's a lot of interest in suicide and concern about suicide, like increasing in the Syrian context. So the problem in Syria, we didn't have any tracking system or surveillance system to follow up on the suicide cases and come up with the risk factors. This is not before the revolution, not after the revolution, so we don't have any baseline actually. So what we found online is one innovative idea in Bangladesh was done in Bangladesh, where they screened news outlets to find out cases and analyze them. So we repeated the same idea in the Syrian context. And we brainstormed the news outlet that is famous and reporting in the 3 areas in Syria, northeast and in the regime-controlled area. And we came up with the 26 news websites and outlets. And we searched all of them, and we analyzed the first 3 pages of the results. If they have high yield of results, we included them in our study. So, and then we came up with 12 outlet news, and we analyzed all the data or reports on these outlets over like 6 years. And we put the data in Excel sheets, and we cleaned the data, deleted the repetition, and also cross-matching information from several articles or reports that talk about the same cases to get the most accurate one. These are the media outlets that we analyzed. So this is in Northwest. Usually they report in Northwest. This is in regime area controlled, and this is in Northeast. Okay, now the result, of course, we know that the media reports maybe not be accurate. However, we will see that some results, it is very reliable because it was reported in almost all cases, like male and female. It was reported in all cases, and it is easy actually to define this factor and to report it. So we think that some data is like very valuable and validated, while the other information, like the results or causes of suicide, it is a complex factor and it is difficult to know and to report. So maybe not so valid. However, they still can give us some insight about some important factors. So we actually explored since 2016 till half of the year of 2022 till June, and this is the cases that we or percentage that we have, and we can see that there's an increase in reports about suicide. Okay, and we can see in 2022 we the half of the year almost the same like all 2021. And the number of cases that we come up is 310 cases. Now, for the gender, the cases that was reported clearly, the gender was 309 cases, and we found that 68% was males and 32% are females. And we can see according to each year, always males are more than females. And on the left, you can see the percentage of males over females numbers. So always the male numbers are higher than females. And I think this is give a very valid data actually to consider. Social status, we found that 50% single, 45% married, 3% divorced, and 2% widowed. And the cases was 128 cases that reported about this social status. Average age was 26 years, with the least number was 9-year-old, and the oldest was 79-year-old. And this is according to distribution, according to the age groups. And as you can see that 2/3 of cases are under 30%, sorry, 2/3 of cases is under 30 years old. And the cases that included the age, it was 238 cases. Also, difference between countryside and city. So we found 66% in countryside, 34% in city. And this is the distribution in provinces. And we can see that Aleppo is most prominent in the number of cases, and the rest of other provinces. So this is show the differences. Residence type. So we had 79% who are in host community or residents, 12% refugees, 6% in camps, and 3% others. Academic levels, postgraduate was 3%, undergraduate or university students, 34%, high school, 26%, middle school, 34%. Occupation, only 38 cases reported the occupation, and we can see the cases, but the workers was the most prominent occupation. One important risk factors or feature of suicide is the method. And we can see that hanging is the most prominent cause. And it was the suicide methods was reported in 281 cases. And we can see that hanging is the most prominent among the suicide, and then shooting, and then jumping. However, if we disaggregated the data according to gender, we found that hanging is more in males, but the most prominent in females are poisoning. So yeah, this is also insightful like differentiation. Days of suicide at house, it was 60% at their house, public facilities 18%, a building 6%, and there's other places. And also cause of suicide. And actually this is like interesting, and maybe it can generate more research and in the future. So we found that the number one is difficult living conditions. After that, relationship issues, then psychological issues comes. So only like 14% mental health or psychological problems that's prominent. And this can pose a question: is suicide a mental health problem, or it is more a system problem? Not only health system, but all the society system. And we need to consider it as a complex from a system thinking perspective, more than narrow perspective. Now, you know that some suicide cases, they leave some notes to their family or about their suicide. So we found only 5% of the cases left a note. By month, we see that most cases are in February and less in November. And it was reported in or figured out in 279 cases. And this is according to the season. So in summer, it was highest in 30% and less in autumn. And between night and morning or daytime, it was like almost equal, 45 and 55. Now, I will conclude with comparing this data with some other sources to see how much this data can be reliable. So there's what we call it, General Director of Forensic Medicine. That report about cases. And this is in the regime area that report about all the cases of suicide. And we can found that in first half of 2022, you can see that also males and females percentage are almost the same. So 76% at their report, and our report is 60% at the same period. Aleppo also, that was the most prominent province with these suicide cases. And also, actually, hanging was also the most used method of suicide. So this is the report validate our findings, actually, or support invalidating. The same in the year 2021, actually. Although the number of cases is different, so they got 157 cases and we got 77 cases, the percentage is the same, exactly the same. 69% are male and 31% and female. And again, Aleppo was most province that has suicide cases. and hanging again, the most prominent method. And the same in 2020, the same data, and also in 2019. This is what I wanted actually to present, and I'm open to your question. Thank you very much.
Thank you so much, Dr. Mohammed. I'll open the floor to questions. I can see a question here.
Just my question is that.
Sorry, can you just use the mic?
Thank you very much for this very interesting presentation. I just want to know, like when you were showing the percentages by age, it looked like the highest percentage was for the children aged between 10 and 19. So is there any explanation for this?
Yeah, actually what I wanted is just to present what we found. However, for explanation, we can have a lot of speculation about why is this happening. We know from the Western literature, there's two ages that have higher percentage of suicide. We have older age and we have adolescents. Okay, so what we found now, it is like adolescents have higher. So that means, I mean, it's validated data, and I think maybe as if we can connect it with like relational problems. So this is the age where there's a relation, right? Start having relations. So maybe this can have a cause of this period of life, impulsivity of this group. I think also can increase this. So this is my explanation, but of course you need more to see maybe deep more in the causes of this. I hope this answers your question.
Thank you. Any other questions? Yeah, we've got a question at the back there.
Thank you. Thank you for reporting on this obviously very important and very heavy issue. I wanted to comment again on the ages, and I wonder, because you looked at media reports, whether it would be more likely for quite a shocking or newsworthy suicide to be reported on, and if the unfortunate victim is younger, it's more likely to be reported on. I wonder if you had any thoughts on that.
Yeah, of course. I mean, this is one of the weakness. Like, we are relying on media reports, and usually media report things that are interesting for them, right? That can make a very interesting and buzz effect, right? So we don't rely much actually on that. However, when we combine data and we maybe triangulate this, and then we check with other maybe context, I think we can come up with more insights. Like, for example, in Bangladesh study, they found female rates are 60%. They are more than male, for example. However, hanging was the most used method in committing suicide. So maybe when we triangulate this data with other reports, this can help us more. And my aim is in this study is to have a benchmark information, then more thorough, more rigorous research can be done to compare and contrast with this baseline.
I mean, can I just comment on this?
Yeah, definitely.
I was involved in developing the methodology with Dr. Mohammed a little bit. So I think we try to reduce this bias of media by relying on media from different regions of areas of control, because basically the more attractive news for media in the regime-held areas are different from the Northwest and from the Northeast. And when we triangulate information across the media sources from different areas of control, I think this bias will be mitigated a little bit, but definitely there is room for bias. And secondly, I think there is a need to add maybe some expert interviews or maybe interviews with community members to help in interpreting this data, which I think this is the next phase that we discussed for this research that is still ongoing, and hopefully there will be a joint publication. And it is important actually that Syria Bright Future as an NGO working in the mental health issue in Syria since I think in the early beginnings of the conflict is the leading agency for this research. And this is part of our R4SSS actually focus, that we work jointly with organizations to help them advance their research skills and also for us to learn from their experience. Thank you, Dr. Mohammed.
Brilliant, thank you. I just also have a question and comment about the idea of relying on the media. So it's, as you say, it's really interesting. It would be really interesting to compare and contrast that with a different source of data as well, to see whether maybe a part of the increased reporting is also to do with the stigma that's often attached to this, and especially in our part of the world, let's face it. So it's also a question of, now more and more people are wanting to talk about it and trying to break down those barriers to, about talking about mental health generally. And I'm assuming suicide even more so because the links to religious factors and all of that. So I wonder whether that's also a contributing factor for the increase in reporting on the media is because, people are trying to break down that barrier.
Yeah. Dr. Karim, want to comment?
Yeah, please, Dr. Mohammed.
Yeah, actually, this is always the problem. Do we have more incidents or more reporting about these incidents, right? So for me, I'm cautious on like giving more confidence in the data. We trying to fill gap, let's say, but we need a lot of work actually. There's a lot of, suicide is more complex phenomenon than to be described by numbers. Okay, so I think by time we maybe more work will be done. We will be working more on these topics. A technical working group in Northwest Syria also is having a task force for dealing with suicide, and also there's many plans to do research. So now there's a lot of interest in doing research about that. However, again, I want to emphasize, because I'm a fan of system thinking and systems in general. I think suicide is a system problem, and we need to tackle it from different angles so we can deal with it. Thank you.
Absolutely. Thank you very much for that. I see one quick comment, Dr. Munder, and then we have to unfortunately move on to the next presenter.
Thank you. Hello, Dr. Muhammad. Actually, I just want to ask you about a question. When I was in Idlib in 2019, I registered almost 127 cases in that year through my personal communication with the director of hospitals. And the official number at that time was almost between 30 and 40. And also from my experience as an orthopedic surgeon in Aleppo before 2011, and even in Idlib after that, most of cases, that parents ask the hospitals not to record these cases as suicide. So we used to register these cases as accident or any other reason. So I believe that the real number, more than official numbers, I don't have like solid number, but I believe that the real number absolutely more than what is in the report in general. Thank you.
Yeah, thank you, Dr. Munder. Exactly. We think that the real number is more higher because some was not reported and some was like even hidden, because the stigma. However, I just want to clarify one thing. Why do we need risk factors and demographics? Like, we as practitioner, if we have a case with suicide thoughts, how can we evaluate the risk? So we need to ask about the symptoms, but also we need to have some demographics to decide how to deal with this case. So if I have like a male who are young with suicide thoughts, it will be different to deal with women who are like 50-year-old and has suicide thoughts. So the risk factors affecting my decisions not only the symptoms itself. So for that, we are in need to define the risk factors. And I think we came up with some risk factors that we can rely on, like the male and female gender. However, we need to see other factors that play a role, maybe ethnicity, maybe other maybe diagnosis and other factors. Yeah, so this is actually the benefit of such results, but it is we cannot actually cover all the cases. Thank you.
Thank you so much. I see there's one more question online. Clearly, people are very engaged. So let's take a quick question online.
Is it me? I mean,
yes.
Yeah. So I mean, just again, I think all questions raised are important. I also want to a bit defend on the methodology that Dr. Muhammad and Karim actually engaged in developing this approach, because it's difficult also to get information about the suicide, given also the unstable situation and uncertain conditions. But the main big gap, because we're not talking about only the psychological issue, the main big gap is about this gender issue. I was surprised to see this huge difference between the WHO report in 2008 that showed the ratio, male-female ratio in Middle East is 1.1 to 1. So it's very, very close in Middle East, comparing even other parts of the world. So of course, the underreport here, it's definitely clear. But I mean, the social factors, given the situation that women are facing in such a difficult situation, shouldn't be actually underestimated. And that's why maybe it's important, if we have such a difference between male and female in this study, to look beyond the numbers and to see, maybe it's a second phase of this study, about the the other factors or the hidden factors, or that could actually give more light on the gender and especially women difficulties that they face. So just I see among all these issues, this gap is quite of significance. So to mention to this, Dr. Muhammad, and thank you very much. This is really important.
Yeah, thank you, Dr. Fouad. Actually, one idea that maybe we continue with this research is try to study the relation, like what is the relation with the method of the suicide with the gender, for example, or the cause that is reported and the gender and so on, and the age and all these. So maybe we can come up with a more complete, better picture about the cases who are committing suicide. So thank you very much for your.
Thank you.
Thank you so much, Dr. Muhammad, once again. So now we'll move on swiftly to the next presentation. The next presentation is about an overview of family planning services in terms of access, beliefs, and barriers. And it's looking at results of a cross-sectional baseline survey in Northwest Syria. It's going to be presented by Dr. Abdessalam. Dr. Abdessalam is an ENT surgeon, an MSc holder in epidemiology from the London School of Hygiene and Tropical Medicine, and a traveling scholar. He serves as the senior strategy advisor for the Syria Relief and Development, SRD. He also plays a leading humanitarian role in Syria's civil society and represents Syrian NGOs on the SSG. Dr. Abdessalam has worked in multiple makeshift hospitals in East Aleppo, and along with his colleagues has founded the Aleppo City Medical Council in 2012 and the Free Aleppo Doctors Association in 2014. He also participated in establishing the Free Aleppo City Council, an office in areas where it's no longer under the control of the Syrian government. Abdessalam was elected as the head of the health office of the Aleppo City Council in 2013 and was also elected as the head of the health office in Aleppo Council in 2016. Thank you very much.
That this might not capture that. That's the only thing. and it doesn't also try and include any trauma symptoms, which is not
Yeah, so
necessarily
if you just use that mic, and then there's a clicker there to control the slides.
generalizing behavior problems are common.
Many thanks for hosting me. I'm pleased to be with you and to present our research, me and Dr. Uqba. I will present the first part of this presentation, and my colleague Dr. Uqba will take the lead to present the rest of this presentation. Actually, the ongoing conflict in Syria since 2011 had led to severe consequences on the health system, particularly in sexual and reproductive health services in Syria in general and in Northwest Syria in particular. Despite women's reproductive rights, providing family planning services for population in conflict settings and in humanitarian settings is still challenging. Actually, there are several factors ranking from lack of information about services, lack of information about family planning, in addition to lack of support from partners and the community to access family planning services. Fragile health system have severely impacted the health services in Northwest Syria due to a systematic attack on health services, lack of funding, and interruption of supply chain. The main aim for our study to guide the program activities and serve as baseline to build an ideal humanitarian response that meets essential family planning and reproductive needs in Northwest Syria. Actually, before this study, there was lack of information about family planning services, and particularly after a lot of changes in the structure of the community in that area. We had 4 objectives for our study. First one, understanding community beliefs toward family planning services. Second, describe the family planning needs and desired methods. Third, investigate barriers to utilizing family planning services. And finally, develop essential strategies to provide reproductive and family planning services and respect to beliefs and cultural norms. In this study, we conducted this study in Northwest Syria, in Aleppo and Idlib governorates, in 41 locations. More than 7,000 community and base facility surveys of married men and women of reproductive age were carried out to identify baseline family planning measures, perceptions, and knowledge of contraceptive methods. Data were collected via trained staff and using Kobo software. And this data we imported to Stata software in order to do descriptive analysis. I'll stop here and over to my colleague Uqba, should be online, to present the results.
Thank you, Dr. Absalam. Thank you all. So, I cannot see the presentation now on the screen. So, okay. So as Dr. Absalam mentioned, like this study was aimed to have an overview on family planning program for Northwest Syria and know how to design this kind of program, especially with like saying that sometimes like maybe religious and social norms may like stand against planning and implementing family planning program in Northwest Syria. So we start with the conducting these surveys for more than 7,700 women, girls and men, boys in Aleppo and Idlib areas. More than 90% were female, so the focus was more on women and girls. while we also try to see the perspectives of males in the family planning programming. So around 10% of the sample were girls under 18. Firstly, we looked at the percentage of early marriage in the community that we surveyed. So you know that like early marriage can affect the need of family planning, because those who marry under 18, they are in need to family planning more than others. So early marriage was like registered on 38% of the sample that we surveyed. So only like 37% of girls under 18 were using family planning methods. Can we go to the next slide, please? So for looking at the contraceptive prevalence rate for modern family planning methods among women at the age of 15 to 48 in Northwest Syria. So it was in this like research achieved 66% in comparison with the that's like was published by WHO in 2008. The CPR, the contraceptive prevalence rate was 58%. So 81 of the interviewees support using family planning, while around 19% like concerned about various factors, including religious, culture, and social norms. So most of the community were supporting using family planning. Next slide, please. Approximately 50% of women define family planning and as controlling the number of children, which is like good, while 17% understood that is like the family planning is interrupting pregnancy and prevent women from having any more children. And that was one of the reasons behind like not using family planning, because they thought that will cause infertility, or like we will not be pregnant anymore after using these methods. 62.5% reported that using the method was effective to prevent pregnancy when they use it. Next slide, please. So IUDs, intrauterine devices, were the most preferred family planning method in 38.8%, followed by the contraceptive pills in different like combined the mini pills and the emergency pills, all of them in this contribute to 14.9%. And then injections followed by the neutral methods. So 98% of the interviewees have concern about the side effect of family planning methods. Around 40% of women experienced side effects that promoted them to discontinue the use of contraceptives. So we found that mainly like women who even not using family planning or discontinue using family planning was because of the side effects of family planning, and like mainly because they don't know more information about these side effects that could be like related to the counseling of providing family planning. So when they saw any side effects, they just like not use this contraceptive anymore. Next slide, please. So IUDs and OSPs, the oral contraceptives, are the top of the list, which cause a bad side effect for women who use them, with 45% for IUDs and 23% for oral contraceptives. Only 1% of the respondents say that will not use family planning due religious reasons, haram. So before we heard a lot that maybe in Muslims area they will not accept family planning because they have religious reasons, and we found that only 1% of the community refused family planning because this reason. 3% of the causes involved that the man refusal to allow a woman to use family planning methods. Here we can find that mans have the decision sometimes to use family planning, and they prevent women from using them. So it's important to engage them. And primary healthcare centers, PHCs, were the most common site for accessing family planning methods. More than 50% of people reaching PHC to access family planning, followed by the hospitals in 22%, and then the private sector in 16%. Next slide, please. So here, what women and girls prefer to use as a contraceptive in Northwest Syria. So mostly, as I mentioned, IUDs come first, and also bees, then other kind of contraceptive, including injections and natural methods. Next slide, please. When we ask women and girls about the current methods that they use, again, more than 23% they are using IUDs, the most common method, and then in 14% they are using oral contraceptives. Then it comes to neutral methods, and then injectables and condoms lastly. A few was using surgical methods, as you can see. Next slide. So this is about the strengthening about this kind of research. So this is the first research that we tried to reach a large sample to cover multiple locations in Northwest Syria to look at the prevalence of family planning after the conflict, so we can have an idea how to plan a family planning program. Looking into the barriers to accessing family planning and filling the present gaps should enhance the quality of program. So that this survey encourage us to do more in-depth studies about the key finding that we have. Findings generated from this study may be helped to improve family planning program in other similar conflict setting. Next slide. So for limitation, as you know, cross-sectional studies cannot establish a cause and effect relationship over a period of time, since it's conducted for in specific time. And selection bias, including that the main target was for us, those who are visiting health facilities. So we couldn't in small sample that we could reach women and girls who have no access to health facilities. And even we have this small percentage of girls, because most of those who come into health facilities are women. Next slide, please. So, Dr. Assam, do you want to continue or I? What?
Thank you, Dr. Aqba.
Yeah,
So
thank you.
the conclusion and recommendation based on the result of our study, this study illustrates that family planning services are desired and welcomed by Syrian women who are living in North Syria, which is against some thought before conducting this study that the people, they are not welcoming with family planning, particularly after the crisis inside Syria, and particularly in Northwest Syria due to several reasons. This study found that the various family planning services were provided at the time of conducting this study, and the preferable method are IUD, or following by contraceptive pills and then injections. Our recommendation sustainability of RH kits and including family planning as part of SRS services package and primary health care service package is crucial to maintaining the accessibility to life-saving services, because it is life-saving services. In addition it is important to improvement in awareness, since awareness play a key role in addressing barriers such as poor information about family planning services availability and possible side effects, and also engagement and those in awareness activity, particularly about early marriage. Thank you.
Thank you very much. I'll take some questions from, if there's any questions here, and then we'll see if there's questions online as well. So there's a question at the back, if we can just pass the mic. Thank you.
Okay, hi, thank you. I just had a question about consultations provided, if they were, and the quality of consultations, if you have any data about that, because you mentioned a lot of like implications around, you know, information and education. So yeah.
At the time of conducting this study, as I mentioned at the beginning, the main aim of this study to guide the family planning program to have ideal implementation inside Syria. At that time, unfortunately, there was no any kind of awareness. There's some women who already know about this before the crisis. Before the crisis, this service was available through primary health care centers. It's free of charge services. There is some awareness before the crisis. So the main concern were regarding the new generation. So the new generation, their lack of information about what is family planning mean. More than, let's see, about 50% of the interviewees say that it is just minimize the number of children. They don't know a lot about this information except the people who know about this before. So this study was at that time of conducting this study, there was no activity at that time. This study was conducted a survey in 2017. So.
Thank you. Any other questions from the room? Yeah. Yeah, sorry, can you just, yeah, thank you.
Thank you so much. So can you hear me? Yeah, thank you so much. No, just one comment from my side. I think this study could also inform some advocacy related to the renewal of the cross-border resolution, because one of the biggest impacts of the stop of cross-border support in North Syria has been the lack of reproductive health kits. And in this case, the lack of kit 4, if I do not mistake, but also kit 3 with the post-exposure prophylaxis, etc., that had a huge impact on family planning, because NGOs in general have issues in procuring such items. So this could definitely inform the advocacy, I mean, because it's one of the areas that might be impacted the most. Thanks. And thanks for the study.
Very interesting comment from your side. I think one of also the main reason to present this data at this time is part of the advocacy. And one of our recommendation, it's like sustainability of RH kits inside Syria. And just in case none were of cross-border, it will have huge impact, not just on SRH and family planning service in the whole response in South Syria. And hopefully we'll have alternative solution to overcome these problems if this happens.
Thank you. I see there's a comment online. So would you like to ask your comment? But I can also read it out loud. So for those who experience side effects, did they seek medical help before they decided to stop?
I think Dr. Atba, this is more technical
Yes.
for you. Over.
Thank you. Like to answer the previous question, as you mentioned, like UNFPA and like through the cross border, they are providing like kit 1 condoms, 3 for rape, 4 for the OCPs and injectables, and 7 for IDs. And they are the main and almost the only like source of this family planning methods in Northwest Syria. For the for those who experience side effects, most of them they didn't return to health facilities. And that's why I mentioned like counseling on family planning. That's one big issue. Actually, this like study encouraged us to do more in-depth like inquiries about like family planning program. So we like for now we are doing a new like looking in depth, as I mentioned, like we interviewed medical staff who are working on facilities. We conducted KIA with the organization who are implementing family planning programs. We conducted FGDs in like multiple district inside Northwest Syria to look more about the barriers and even how much like attitudes in one of the like the assessment for medical staff. We found that like 47% of medical staff have negative attitude towards like survivors and those who are requiring even more than 58, I remember like this person that they refused to provide girls under 18 with family planning methods. So I think more research should be done to look in depth.
Thank you very much, Dr. Akba. Just one last question, and I see my colleague Zahid already, giving me the look. But just a quick question, because actually at MEHAD, or previously also in France, we did a similar survey, but it was focused on the community level. So it was a community-based survey, not a health facility one. And the values that we got showed a much higher demand actually for family planning. Sorry, a lower demand for family planning within the community compared to your findings. So it's interesting. I just wanted to ask, was the sample, so the people that you selected within the sample, were they already accessing the health facility for family planning services? Or was it just kind of like a general patient database that you sourced the sample from?
Yeah, thank you. As I mentioned, at the end of the presentation, mainly those who are visiting health facilities, but also through community health workers, we reached some of women and girls in the community. However, even just good to mention here that within the SRH technical working group, the sexual and reproductive health technical working group, we are collecting data from different, all the facilities inside Northwest Syria. So we just estimate also again the prevalence of family planning methods. We cannot do that from data, it's from surveys, but that just to look that the new users of family planning compared to divided by the estimated number of women at the reproductive age, equal 62% also. That was generated by the SRH technical working group this year. So if we compare it with the number that we present, it's so close.
Thank you very much. Okay, thank you to all presenters for the really interesting presentations. We're running a bit behind schedule, so we'll move swiftly on to the next presentation, which is actually a skills workshop, so looking at specific methodology in more depth. The fourth session for today will be exploring a topic, so a research study looking at system dynamic approaches in health research and conflict settings. So our presenter, Sharif Ismail, who's a Wellcome Trust clinical research training fellow at the London School and a resident in public health medicine in London. He splits his time between academic research and service work in public health, working as a health advisor with DFID in 2018 and 2019, and most recently for Public Health England, supporting the UK's COVID-19 response in 2020 and 2021. He's completing a PhD on health system resilience through a focused case study on vaccination delivery across populations in Lebanon since 2012. And he was previously on the steering committee for the Syrian Public Health Network, and his presentation would be about his research titled Vaccination Delivery System Responses to Compound Shocks, so pathways to influencing system resilience in Lebanon. Thank you.
Thank you.
So 20 minutes, yeah? 15.
Okay, so really good to be with you. I was sorry to miss the talks this morning, actually. It's looks like it's been an absolutely fascinating day. This session's going to be a little bit different. Sorry, got it. So a little bit more of a skills focus. Basically what I'm going to do is run through a bit of a description of system dynamics as a method and then show how it's been applied in the context of my PhD project as an example of what you can do with this sort of approach. But I'm aware there are lots of people online and probably some in the room who've already used systems thinking in their work. So this is going to be perhaps a bit of a recap for you guys. So just before we start though, it'd be really helpful to know how many people use systems thinking, would they say, in their research? Great, okay, cool. Just at the beginning, I'm going to run over some basics on systems thinking and then talk about system dynamics specifically before going into the project. And I guess the logical starting point is to ask why on earth you would bother using these sorts of methods at all. And mainly this comes down to the fact that health system behavior on the ground is often very difficult to predict. There are all sorts of things going on from a management perspective, which are quite difficult to sort of keep a track of. And there are features around the way that systems operate in terms of the relationship with operating contexts that are very changeable over time. So you see quite a lot of emergent behavior, perhaps even feedbacks within systems. And one of the problems is that a lot of conventional research methodologies are just not very well set up to capture that sort of behavior. So systems thinking approaches allow you to view systems problems that in a way that sort of captures some of those aspects. So they focus particularly on patterns of behavior, causal factors that influence system behavior, and particularly this aspect of change over time. So you're not really looking at cross sections, you're looking at what's happening in the system over time. And there's a whole variety of different methods you might use. This is a table from a sort of summary textbook of methods on systems thinking, but it very much depends on what you're trying to do. There are methods that you can use simply to describe kind of what's going on. What's the system that you're looking at? What are the limits of it? There are approaches you can use to try and understand what's going wrong within a system. So there's a whole bunch of methods here, but you might use things like causal loop diagrams, which I'm going to come on to in a second. And then at the other end, there are approaches that allow you to actually prospectively test potential interventions. So these push you more towards the realm of modeling as a way of getting a handle on what might happen if you try and actually implement an intervention in a given setting. So in this presentation, I'm going to focus entirely on system dynamics, and there are basically two main methods involved in system dynamics. So one is sort of highlighted here, that's the pointer, causal loop diagrams, and the other one, which I'll come on to in a second, is system dynamics modeling. And essentially, causal loop diagrams are causal maps. You build a map of all the variables that you think contribute to a health system behavior that you're interested in. And you model out, using arrows, essentially causal relationships between those. And very often, this is done through very close engagement with stakeholders. I'll come back to that later on, because that's one of the main advantages this sort of method has over other approaches that you might use, where data is quite patchy and difficult to get hold of. It's really very heavily reliant on building a picture of what stakeholders think is going on in the context in which they're operating on. But when you build these causal maps, what they do is give you a sense of the system's structure. So it won't allow you to predict, in a sense, what's going to happen further down the line. For that, you need to move to system dynamics modeling, which is quantitative, and I'll come on to that in a second. But just to give an example of what this looks like for a causal loop diagram, this is a very crude example. I want to emphasize that. But what this diagram does is map out a very simple sort of feedback relationship between mothers attending antenatal care settings, having deliveries in hospitals and receiving postnatal care, health worker workload, waiting time, and then neonatal survival. And the idea here is, quite simply, if you have more mothers going into health facilities to receive these forms of care, health worker workload is going to go up, waiting times will probably go up as a result of that, and you get a negative feedback effect because mothers are increasingly aware that waiting times are going up, they probably won't go into facilities as much. And there's a positive relationship between mothers attending those consultations and facilities and neonatal survival, which is modeled out there. I guess the other sort of takeaway from this is just something around the notation, which I'll come back to in a few minutes. So the arrows indicate the direction of causal relationships, and if it's a positive relationship, you model out the plus. If it's minus, it's a negative relationship. So you've got a bit of a negative feedback going on here. And the point about this is it enables you to have a bit of a sense mentally of what you think might go on over time in the system. And so this is modeling out neonatal survival over time, depending on how this relationship is playing out. So in a best case scenario, you might see a progressive increase in neonatal survival. Perhaps in the worst case, this bit of the loop where health worker workload is rising and waiting times are going up starts to dominate. So that pulls this bit of the feedback loop down, and neonatal survival may even start to decline. So what you're trying to do here is get a sense of what the interplay between these different variables are and what that might result in terms of system behavior. System dynamics then takes these sort of visual representations and turns them into quantitative models. And the point about this is not to predict, with absolute certainty exactly what's going to happen in the future. It's a way of modeling out potential scenarios. So if you're a policymaker trying to work out what might happen to your system if it gets hit by a major shock, or if you have, I don't know, a catastrophic loss of health workers for whatever reason, you can use this method basically to model out the range of potential outcomes you might see. And that's quite useful from a policy perspective, because you can then think about things you might do to change things around and test the impact of potential policies. So that's a sort of whistle-stop tour of those two methods. And what I'm going to do now is just walk through how I've used this in the context of PhD work in Lebanon, which started back in 2018. So quite a lot has changed since then. The original framing of the project was around Syrian refugee movement into Lebanon, what sort of effect that had in terms of delivery of routine services, and particularly on transformation. So it was basically a project about system resilience. And this was the definition I was using. And one of the reasons why I decided to use system dynamics in this project was because of this emphasis on the dynamic sort of sense of what resilience is. It isn't a static property. It's about a system's ability to change quite proactively in response to changing circumstances, obviously guided by the people who are working within it. And in terms of vaccination, so that was picked out as the case study here because of everything we know about its effectiveness as a public health intervention. It's often a top priority in humanitarian settings, but we know that in conflict-affected settings globally, there are real issues about maintaining coverage. And although Lebanon had historically very high coverage, at least according to the official statistics. There were some real issues emerging in terms of coverage within host communities, and obviously an awful lot of concern about how to maintain coverage amongst Syrian refugees moving over the border, given historically, again, quite high coverage in Syria pre-conflict. From a fairly straightforward-ish beginning in terms of looking at refugee movement, this then became a much more complicated project because of what was going on in Lebanon at the same time, looking at the impact not just of refugee movement, but also of COVID-19 and of a multi-dimensional political and economic crisis, which is still ongoing. And one of the other advantages of a method like system dynamics is it enables you to look at multiple exposures on a system at one time, because you're basically mapping out relationships between factors and a system structure that you think is broadly stable over time. It's the behavior of that system that changes. Just for a little bit of additional context, this was the sort of system behavior over time that I was interested in looking at. So what we have here is a trend line for first dose measles containing vaccination coverage nationally in Lebanon over time, and measles caseload along the bottom. And the point here was just to keep this in mind in terms of the sort of outcome that we were looking at. Now, there are enormous issues around data quality in Lebanon, spanning both host community and refugee populations, which we can come back to in the Q&A if anyone is interested. But that was the sort of outcome trend over time that I was interested in trying to explain. And so what I did in this project was run through a whole load of stakeholder interviews. So it was entirely qualitative. And what I'm going to show over the next few slides are a bunch of causal loop diagrams from the project. But what you're doing in system dynamics is taking a data set and looking for what it tells you about causal relationships between variables. So in this case, it involved looking at interview transcripts and just picking out causal language and identifying variables from those. There's a sort of specific process by which you can do that. I won't spend a huge amount of time on that now because of time, but there are a variety of ways in which you can approach this. So you can either do an interview-based approach like that. Quite a few research groups do group model building. So you essentially build a causal loop diagram in a room with a bunch of stakeholders who you think are relevant to the problem you're interested in, and you test it with them. And so you do that over the course of perhaps 1 to 2 days. So in terms of what this gives you, this sort of approach, a couple of snapshots as illustration from the project. So this is a sort of macro level view. Red variables here, or red objects here, are the shocks, and then some of the major loops. And what system dynamics enables you to do, among many other things, is to pick out key delays. That's what's indicated by these hash lines. So they're pathways within the system where really important delays in the movement of something like information from one part of the system to another, or perhaps material. So in this case, supply chain issues were really, really prominent in determining how responsive the vaccination delivery system was in Lebanon. So it enables you to identify where those key into the system. And that's a very sort of crude illustration. But if you look at it at a slightly more meso level, so this is a visualization of the supply chain and logistics system for vaccination delivery in Lebanon. And this is focusing just now on publicly supported facilities. Again, through interviews with stakeholders, we were able to identify a whole bunch of delays. So there was information delay at this point in terms of a delay from refugee movement to recognition of the scale and scope of that movement, to that then informing vaccine dose projections that were likely to be needed for the next 6 to 12 months, say, and then how quickly those doses were shipped into country and distributed down to facility level. And one of the things in the early stages of the Syria crisis response in Lebanon was that there were real problems with cold chain integrity at facility level. So facilities, quite frankly, weren't able to cope with demand as it was rising over time. And part of that was because the cold chain at local level wasn't strong enough. Fridges weren't big enough actually to take the number of doses. So quite a lot of system strengthening work at this sort of level in order to bolster cold chain strength. And one of the things that you saw in the context of the economic crisis a little bit later on was quite an interesting phenomenon where an effort to try to shore up resilience in the system initially by introducing solar fridges at facility level actually kind of fell apart during the economic crisis because these were imported fridges entirely dependent on spare parts sourced from overseas. And as the economic crisis worsened in Lebanon, currency depreciation and so on, it's been increasingly difficult to get those spare parts. So that part of the loop has sort of fallen apart a bit. And what's happening now is a situation where an awful lot of facilities are working on a just-in-time basis. So they have enough vaccine doses there on site to be able to give to people who they know they're going to see today. Anything else is going up to district level because the cold chain is more secure there, and they just move doses out to facilities as and when they need them. But that means the system isn't as responsive, obviously, to sudden changes in demand. One of the other things it enables you to do is to pick up unintended consequences. So there were some quite interesting changes in terms of the behavior by host communities who historically tended to prefer to go to private facilities for vaccination. And that's sort of intensified in the early years of the Syria crisis response. But again, with worsening economic conditions, an awful lot of Lebanese couldn't afford, frankly, to use private clinics anymore. So you saw a shift the other way. A lot of people, Lebanese citizens, moving back to the publicly supported primary care network, which they hadn't done before. And some donors are viewing that in some ways as quite a positive move, because in terms of universal health coverage and access to vaccination, that's quite a significant change, actually. People can go to public facilities and get vaccination pretty much at nominal cost. This is a very complex table. There's an awful lot going on. I'm not going to go through it in detail, but basically, once you've constructed your causal loop diagram, and you sort of bring together insights like this, so this is an insight affecting just one part of the system, you're able to build up a picture of a variety of different lever points within the system where it might be possible to intervene, potentially with quite significant effects for coverage. And these run in a sort of spectrum of impact. So you have fairly sort of small scale levers, like influencing locally the number of people who go to clinics for vaccination, might have a local effect, but isn't going to have a transformative effect nationally. But as you move down the list of levers, you end up with, system level changes, perhaps, the introduction of wholly new service pathways, the use of mobile health clinics, and so on a national scale that could have potentially transformative effects. And if you then move from the qualitative work that I've described to actually modeling those out, you start to see how you can get a sense of what sort of impact your interventions might have on a system level if you were to introduce them. So that's really the power of this sort of approach. You take qualitative insights from stakeholders, you then build a quantitative model using data that you have available. And the really interesting thing about system dynamics simulation modeling is that if you have points of uncertainty where you don't have data, you can ask stakeholders, ask them, what do you think is a reasonable estimate range for the number of healthcare workers working in facilities in this area? And you populate the model using that. It's not perfect, but it gives you a reasonable sense of what is going on based on insights from people who are working on the ground. So I won't go over that in detail, but I just want to end with a couple of thoughts about this approach, because I do think it has quite a lot of power potentially actually for use in conflict-affected settings. No right or wrong answers, obviously, but depending on who you engage, and that's a really critical question, and what you think the particular problem of interest are, you can build quite comprehensive maps, causal maps of what you think is going on. And then from those, build out simulation models which enable you to do the sort of policy testing I've talked about. Importantly, it's an iterative process. So through consultation with more stakeholders, through adjustment to modeling over time, you can build a better and better sense of what's going on. And I think it's probably particularly valuable in contexts where data, hard data of the sort that you would be used to are scarce. So you can work a little bit more with what stakeholders are telling you. Huge amount of people involved in the project who I need to thank, including Fouad, who I think is on the line, members of the primary healthcare department in Lebanon, and the interviewees who gave time to this project despite dealing with an awful lot at work and at home, which was very generous of them. So I'm going to stop there, and if anybody has any questions, happy to take those now or afterwards.
Thank you so much. Thank you for that, Sharif. Really insightful. I think I'll prioritize the questions online, if there are any, and then perhaps in the 5-minute break, we can also, if anyone in the room has any questions for Sharif, we can also, ask those then. Are there any questions online? No? Okay. With that, then I think we'll go off for a 5-minute break. So if we can just be back in 5 minutes, that would be great. Thank you very much. Thank you.
this is too far. يلا يلا يلا. So now we are into the last section of this conference, one-day conference, and now we are going to be talking about, we're going to have a panel session focusing on health system strengthening and early recovery, and that from the perspectives of experts who actually have a lot of experience from the ground in different areas in Syria. First, I just need to note something that I know that it looks like a panel, but two female panelists apologized last minute. So I know they are experts in everything, but we are, as R4HSSS, we are keen on having equitable partnership between men and women, but we tried our best, but last minute changes. So sorry. Yeah, I know, but it's again, it looks, don't get me wrong, full respect for you guys, but it's it would look bad on social media, which is not what we intended. We did our best, okay? So, as I mentioned, we're going to be focusing on health system strengthening and early recovery. First, we'll be getting the feedback from Dr. Nasir Muhammad Nizamani, he was going to give us his feedback based on his experience in northeast of Syria. Just a quick introduction about Dr. Nasir Muhammad Nizamani. He's a medical doctor with a master's of public health from Harvard University, having extensive experience in health systems in South Asia, Pakistan, and Afghanistan, East Africa, South Sudan, and Somalia, in the Middle East, Iraq, and Syria. He has managed and coordinated large projects on maternal, reproductive, and child health, HIV and AIDS, district health systems, community health and nutrition interventions, and he has worked for various UN agencies and international universities, and he also has teaching and research experience at Aga Khan University. He has worked in both development as well as humanitarian settings, and for the last year he is working in Northeast Syria as a coordinator for the health working group, where he coordinates the humanitarian interventions by the NGOs, liaises with the local health authorities and the donors. Dr. Nasir Nizamani, the floor is yours. Can you please provide us your feedback based on your
Thank you very much. Thank you for this kind introduction. As you said, I'm working with the health working group in Northeast Syria, and I have been listening to presentations since morning. And as you know, it's only the NGOs who are providing health services in Northeast Syria. We don't have UN agencies. And my role is to coordinate their activities. We, as the health working group, do the service mapping. We identify the areas where the services are needed, and we inform our partners and donors to fill those gaps. Our role is also to coordinate with the local authorities. Most of our partners, they are doing what is called humanitarian interventions, which means they have very short-term funding and they are only doing life-saving services. Whereas, as we all know, for health systems, we need long-term interventions. And if we don't have a stronger or better health system, even humanitarian services cannot be provided effectively. So as a health working group, what we have sub-technical working groups on mental health, on reproductive health, but we have identified the need for health system strengthening. So we have set up a separate technical working group on health system strengthening, where this group actually is looking at the issues and the needs, where are the priorities to invest in health systems in Northeast Syria. And as we have been hearing, like even health systems defined differently in different regions. If we look at the building blocks of health systems, first one is the service delivery, which we have already started working. Our partners are providing service delivery, and we have finalized and developed a package for primary healthcare services, which is now a standard guideline for all our partners to follow to provide equal quality services. But other building blocks which we have identified as important pillars that we need, like investment in, and we need those to be addressed as soon as possible. And these are human resources for health. And we heard in the morning, like how people have left the country. And then the people who are there, they are overworked, overstressed. So there is a need to develop more human resources. So that is one priority area. And the other one is the information system, the health information system, as we learned that we don't have much information about surveillance system, but even the regular morbidity data is fragmented. Each partner is collecting their data, but we don't have compiled information about the whole region. So these are some areas in health system strengthening that we have identified as a group, and we are working on these things. And also, other pillar which is very important is the governance. And as we know, compared to Northwest, in Northeast, we have relatively stable governance system. We have one authority to deal with, and they are very keen support developing their systems. So, and then they have even decentralized the health governance up to the governorate and district level through health committees. So this is another area that we as a health working group see as an opportunity to work with local authorities and help build their capacity to enable them to take over the responsibilities of services when our humanitarian partners have to leave. I would like to stop here, and if there are any questions, I'm very sorry that I have committed myself at 3:30 for something else, so I may not be able to stay longer here. But I have my colleague Giacomo sitting there, so maybe he can fill in for me if there are any questions that I said. Thank you very much, and I'll stop here. Over to you.
Thank you very much. Thank you. So I don't know if this question is going to be for you, or I don't know, maybe later on. Okay, so I'm going now, given that Dr. Nasir had to leave, so I had to just introduce him first and then ask him the question so that he can give you a little bit of his experience in Northeast Syria. But now I'll move on to the other panelists who are going to be with us today. So I'll start with Dr. Munder Khalil. He's a medical doctor, a Syrian medical doctor. He established the Idlib Health Directorate, which is the equivalent of the Ministry of Health in other settings, and now he is one of the major members of the R4HSSS group, working as a researcher with more focus on the health governance aspect. And we also have Abdel Karim, my friend here in Kings. So he's Dr. Abdel Karim is a Syrian medical doctor and an epidemiologist. Currently, his work and his PhD focuses on health system strengthening conflict. He is leading this R4HSSS project and is involved in a lot of other projects with other academic and policy institutes like the London School of Hygiene and Tropical Medicine, EUB, Chatham House, and others. And his research focuses on the public health impacts of conflict, protection of healthcare in conflict, health system strengthening, and building health research capacity in conflict settings. He is a regular contributor to several medical and civil society institutions in Syria and has been active in advocacy for Syria through media and conferences. He's a trustee member of 2 NGOs, Shafak and Refugee Trauma Initiatives, a steering committee member of the Syrian Public Health Network, and the General Secretary of the Syrian British Medical Society. And the third person is Dr. Zaidoun Al-Zabi, is a professional researcher and facilitator with an extensive experience in governance and peace building. He helped in establishing several Syrian NGOs and civil society initiatives, but his responsibilities go further than that. At the various levels, he is engaged with the civil society issues in Syria and beyond. He invests in local governance, health governance, networking, youth engagement, humanitarian support mechanisms, conflict resolution, and mediation. A part of his engagement, he took the responsibility to lead research in the field of civil society, constitutional processes and governance, and he is currently facilitating the Women Advisory Board to the Special Envoy to Syria. Dr. Zaidoun will be joining us online, unfortunately, but now, as I told you, we have now Karim and Dr. Mundir. So after getting the feedback of Dr. Nizamani about the experience of the transition from humanitarian to early recovery stage in northeast of Syria, could you, Dr. Mundir, please tell us about your experience, given that you're highly involved up till now in northwest Syria?
Thank you. Thank you very much, Nassim, for having me here. I know this was such a long day with many messages and findings shared by our colleagues. So I will focus just on one idea based on my experience as a co-founder of Idlib Directorate and as the head of this institution between 2013 and 2020 inside Syria in Idlib. And I will speak about the role of donors in rebuilding health systems or the health system in northwest Syria and support the alternative governance bodies inside Syria. And I will mention just for one number from our findings at our Forest Rebels project, as we just finished 3 papers about aid effectiveness and health aid displacement. We published the first one, we submitted the second one, and we are about to submit the third one. I found that the percentage of health aid in Syria between 2011 and 2019 was the percentage of health aid out of health and the humanitarian aid was just 2% compared to 22% in other fragile states in the same period of time. That means donor invested 2% in health aid, which has a development nature, and 98% in humanitarian aid, which has life-saving natures. And I believe that somebody will argue that this is normal when we speak about conflict. And I agree with that when we speak about like 1-2 years conflict. However, when we speak about a conflict that lasted for more than 11 years, I believe that donors should think again about their aid, about the allocation of their aid, especially when we speak about area, 90 to 95% from its health services supported by donors. So the allocation of aid is a critical point. I will give you 3 quick examples. Happened with me when I was in Idlib. The first one, in 2016, I had a meeting with a significant donor in northwest Syria, and they discussed with me establishing a project to support community health workers. And they showed me some amazing numbers and pictures from Pakistan. I told them probably this is a very nice project. However, in Syria, in our health system, even before the conflict, we don't have this component. We don't have community health workers. So we don't have enough experience. We don't know how we can connect them with the primary healthcare centers and with the secondary healthcare center and also with the referral system. Maybe this is amazing intervention. However, we are not sure actually. And first of all, we have to think if we need to create new types of projects, new intervention, or fill our gaps. As you know, we have a lot of gaps because we have very limited resources. Of course, here I don't say that community health workers projects are not important, but I say we were not sure if we invest our limited resources in the right place. The second meeting actually was with another donor. I explained them our plan based on our need assessment 2017. And after I finished, they showed me like a map with different colors. I remember there was like red color and orange and green color. And after I finished, they told me, this project is amazing. However, unfortunately, we can't support this project in this place, in this location near Idlib city, because this area is red area for us. However, we can support this project there at that place because that area has a green color. I asked them what's the meaning of these colors, and actually I was excited because I believe that this is kind of need assessment at the level of donors at high level, and I believe that they will share this map with us after we finish. They told me, unfortunately, these colors related to the military influence. We can work in this area because there are some military groups in this area. We can, in a way or another, agree with them as a policy, as a political level. And in this area and red areas, there are some other military groups we can't agree with them. And for like orange alerts, we can negotiate about some projects in this area. The last example, actually, in 2019, after a severe military campaign against Northern Syria, 70 health facilities were destroyed. I discussed an international NGO about supporting some gaps in southern Idlib, in Jabal Zawiya, where we have more than 200,000 people without any health facility so far, after more than 3 years. They told me, we can understand your priorities, your needs. However, unfortunately, we can't support, we have fund to support maternity hospital in North Idlib. So please, if you have any suggestion, you are more than welcome to discuss this point with us. So, of course, at the end, I don't say that community health workers projects are not important. And I don't say that maternity hospitals or to look to some like safe places to invest in Northern Idlib is not important. And of course, I don't say that donors should not take to their consideration like the political and military changes. However, I'm saying that first of all, they have to redesigning their aid and their allocation, because we speak now about 12 years, almost 12 years conflict. They have to think more about development health aid, not just life-saving services. This is the first point. The second point, actually, I believe that donors should encourage local planning and include local communities, local health authorities, and local medical staff opinions in their strategies and the plans. Otherwise, I believe that donors will do amazing job when we speak about life-saving services. However, when we speak about health system or building health systems, I believe that their role will be at best natural and probably negative role. Thank you.
Dr. Munder, I just want to comment on this. So based on your experience, so there weren't any kind of development projects, at least not in the last few years, even if they are funded for the humanitarian, you know, like it's much easier to provide money for humanitarian issues than for development issues, especially on the political aspect of things. So you see my point? Yeah, go ahead.
I see this was part of the problem. There was a big project to support 8 health directorates in each area outside the control of the Syrian regime between 2017 and 2019, which is a significant project, but the fund was under the humanitarian umbrella. So with the first problem, they just switched and stopped support all the directorate and supported in the state of that some health facilities because it was a humanitarian fund. Even the development nature funds was across the humanitarian umbrella, not through the health aid, was through the humanitarian aid. And I believe this was, to be honest with you, this was part of the problem. And I will give just very small example. In 2016, the number of staff in Idlib Health Directorate was almost 25 members. And as you know, I was there. And it was okay. We deal with limited resources all the time. Suddenly, somebody came to you and tell you that I will pay for 500 employees. So the very small institution became very big very soon. And after 2 years, suddenly somebody tell you that we will stop all this support and your employees probably will decrease again to maybe 5, 6 employees. So I believe that this kind of intervention without real plan and without sustainability is harmful. It was better, and I'm sorry to say that, it was better from the beginning to not support it this way, because we have kind of adaptation with the circumstances and limited resources. But after you pay high salaries for a huge number for 2 or 3 years, it is very difficult to come back to the previous point.
Basics, yeah. Wow. And yeah, this is so. I'm just gonna ask you, given that Dr. Nazamani told us that we will ask you because he had to leave. So, did you sense any kind of change in the funders' behavior in northeast of Syria, so that you can tell really that we are transitioning from humanitarian to early recovery stage? No.
Thank you. No, I mean, how can I say? Like the indications that I've seen cannot be considered a litmus test for an actual transition between humanitarian and early recovery. I mean, we are still in a situation in which humanitarian funding, the humanitarian approach, humanitarian interest, it's still very predominant in the funding environment. However, compared to 4 or 5 years ago, I could see that there have been some funding agencies. Some of them are more big and institutional, some of them are smaller, more linked to decentralized cooperation, that have shown some additional interest to overcome some of the most classic sensitivities linked to this kind of programming. Because, I mean, as the doctor, correct? Yeah. Was mentioning, I mean, this means also supporting directly local authorities, etc. So there are boundaries to this. In Northeast Syria, there are some. In Northwest, in Idlib especially, there are some others because of, how to say, prohibited parties and all these kind of things. So obviously the sensitivities are still there, but I've seen a small change in the appetite of certain donors of funding projects that go more in a direction of strengthening and sustainability and not just immediate life saving. Okay. Yeah.
Appetite, but nothing done so
far.
No.
Appetite meaning that there are pilot projects ongoing, that there is things. I mean, they stay a little bit more under the radar.
Yeah.
Because otherwise, I mean, there are obviously political issues that may be problematic with some of the member states. But there is appetite, and there has been also some initial implementation, let's say. Okay. I don't know if in the Northwest also this, but in the Northwest, this kind of programming actually was already being implemented. Then maybe it stopped, but something like he mentioned in Northeast Syria, still now it's absolutely unthinkable.
Oh.
That they fund the hiring of staff inside the Department of Health, like something absolutely unthinkable at the moment. Maximum, you can have a program that funds trainings for health managers at local level, not even at the department level, because the Department of Health is considered a political entity that is linked to the self-administration, to the PYD, etc. So no, but at local level, the technical committees can be somehow supported without direct financial transfers. So you see, there are still a lot of sensitivities and a lot of obstacles that you have to overcome. But I mean, I think there is a window of opportunity, and I think that NGOs implementing humanitarian programs should be aware of that and should try to take advantage of it.
Thank you very much. Speaking of the window of opportunities, Dr. Zaidoun, what do you think about the whole thing? Early recovery,
grim,
transition.
Very grim, very awful. Yeah. Shall I start immediately, Nazim?
Yeah. Go ahead, please. Yeah.
Okay. Good afternoon, everyone. Assalamu alaikum. This is Zaidoun here. Sorry, I couldn't join you in person in London. I think everyone has heard about the 3 days war that took, or the 4 days war that took place between El Salvador and Honduras over football match. Since these days are the World Cup, it came to my mind when people speak of humanitarian and development interventions during wars. That war that lasted for 4 days is the only exception in all these wars. All civil wars last decades. In average, civil wars last 17 years. So I don't know why donors, UN agencies, INGOs, and Syrian NGOs even thought that this war would last only for a couple of months or weeks, resulting in humanitarian intervention after humanitarian intervention after humanitarian intervention, saying that it's going to happen, this war is going to end in the next few months, in the next few weeks, and so on for 11 years. And this was the result of the number that was just mentioned by Munzer, that 98% of the aid in Syria was humanitarian and only 2% is development. That's not shocking. In fact, what shocks me is like, is it really 2%? That's really even bigger than what, when you think of Syria. Not only this, not only that it is just humanitarian, the politicization of the entire aid. Munzer just mentioned that donors would put a map and look at, this is black, we don't do. This is green, might be risky. This is red, this is government. Which means aid cannot be provided unless we like the authorities prevailing over that geography. Which means the first and immediate impact is fragmentation of the system entirely. So let me give some periods. Starting 2011 until, let's say 2014-15, that was very spontaneous aid, very, let's say, unplanned. And then people thought that, okay, this is a stable crisis. So let's plan our intervention. And that lasted until the first and only in Northwest, first and only, and I believe even throughout the country, development intervention that was just mentioned by Munzer, the support of health governance in opposition-held areas. In 2019, after the overcome of HTS of Idlib, donors started to think, oh, in some areas we have the Syrian government, we don't like it. In some areas we have SDF, we don't like it. In some areas we have HTS, we don't like it. So where do we do our intervention? Possibly in Birmingham or in London. In Syria is no more fit for any developmental aid. Then they felt, well, it might work a bit in Northeast. Not all donors, huh? I would like exclude some of them, but I'm talking about in general. And then they went to Northeast, another wave of fragmentation. This has resulted in, at least, in government-held areas, we have 3 health governance systems. One in Daraa, one in Sweda, and one in the rest of the government-held areas. Although Aleppo and Western, Deir ez-Zor might be also different. With all due respect, Dr. Nasir, in Northeast, yes, I know there is only one authority, and that authority is known for years now, but that same authority has different governance system and I think Dr. Nasir will confirm this. بابا افتح الباب إن شاء الله. بابا افتح الباب لماما. Sorry, that happens when you are alone at home. In Raqqa and Deir ez-Zor, the system is totally different from Kobani, for example. And what is in Kobani is totally different from Minbij. And that is not the result of the donors funding, that is the result of the politics of the de facto power. In Northwest Syria, we have at least 2 governance systems, at least 2. And that is one in Idlib, where you have HTS controlled areas, and the other is where you have the direct Turkish control. So in total, what I'm saying, we're talking about 6 to 7 governance systems for one country. This meant, and this was the result mainly of 2 things: donor money and de facto power politics. We as governance people, or we as health governance people, left helpless. What can we do if HTS wants this? What can we do if the Syrian government wants this? This would mean, first of all, very difficult that these areas talk with each other. Yes, politics prevented, for example, any exchange over COVID. But also, there is no system, there is no established system where these areas can talk with each other. This would mean also that in the future, I don't know how we can reintegrate the country into one system. We are talking now about a global, system where the systems can talk with each other throughout the world. Whereas in that small triangle of Syria, we have at least 6 or 7 systems that cannot talk with each other. This fragmentation is a result of the 2 factors that I mentioned: de facto powers, be it the Syrian government or SDC in Northeast, or HTS and the Turkish government in West Syria. And number 2 is the donor policies. Hence, once there is another human crisis, which is happening right now in Ukraine, trust me, I'm very much pessimistic about it. I'm not sure this will change. How can we change the behavior of de facto powers, and how can we change the behavior of when it all relates to politics? My only small hope in this is that we, practitioners on the ground, understand that if we stay, under the power of these 2 powers and say we will not talk with each other and we will not try to reintegrate our systems, then we are just completing this grim picture instead of fighting back. This means that health practitioners in Northeast, Northwest, and government-held areas should talk with each other now. Otherwise, I don't know how many health systems we will have in the future. Thank you.
Thank you very much, Dr. Zaidoun, for this very valuable input. So, Karim, they say the transition from humanitarian to early stage recovery should be smooth in theory, and there's a lot of nice literature about it. So based on what everyone talked and discussed and mentioned, what do you think?
Yeah, so I will try to link back the discussion that we are having in this panel to the academic literature that we have on health system strengthening. So when I started my health career as a surgeon, so I knew little on health systems. And then because of the conflict in Syria, and we were confronted with emerging threats that required health system response, for example, the polio response in 2013. And we started as practitioners to think of, systematic approach that, provision of health services is not enough. So we need to think about supply chain, we think about information and others. So when I started thinking of health systems, I tried to simplify, as practitioners, as NGOs, we try to simplify things. And I wonder if I can share the slides, please. So I try to think of something like this, which is the control knobs of health system framework by the World Bank, which is a very simplified version of health system. I think I'm presenting these examples because I believe that part of the problem of health systems strengthening in complex settings is related to the way we understand health systems in complex settings. So this simplified version, as a practitioner, helped me to think about some issues related to the supply side. That if we, for example, I was working with Save the Children, that if we secured some funds from, and we were able to secure some funds from Gates Foundation, then hopefully the issue will be solved and the performance and the outcomes will be improved. But this was not the case.
because there is no causal. This arrow here is by no way it's causal. Next slide. So other frameworks looks at, which is the most common framework, which is the 6 building blocks, looked at the outputs, the inputs, or the demand, the supply side, and some outputs. But again, I think there are some missing elements in terms of community engagement, demand side, values, and principles. And I think one of the problems of health system strengthening approach and analysis that is dominated by this exact framework, which is the 6 building blocks. Next. And also USAID, for example, as a donor, they use something very similar. So as you see, the input side or the supply side, basically we have these 6 building blocks more or less. Next. But there are some health system frameworks, only recently in 2018, actually, there was some more thinking of different approaches of understanding health systems that we need to think, for example, about population, about governance, and all the discussion that we've been hearing are focusing on these elements, about the workforce, the tools, elements. So I think there is an attempt to move away from focusing only on supply side, trying to focus on demand side. But the problem that the applicability of these health systems in conflict settings are very limited. Next. So when it comes to conflict, conflict goes through different phases, and most of the frameworks that we've seen are applicable in or were developed for stable settings. So when we think of conflicts, we need to think about a different health system framework for each phase of the conflict. Starting from the pre-conflict, active phase, post-conflict, early recovery, and stable settings. Next. I tried to develop this for my PhD thesis, actually, to develop a dynamic health system framework that can, move, and change goals and outcomes and dynamics throughout the different phases of conflict. For example, definitely in the active phase, we need to focus on life-saving. But as we go towards more early recovery, we need to think about social and financial protection. And again, I think later, we need to think about universal health coverage. Next. And also, all of this is happening in an environment of different determinants, especially social determinants. And also, community engagement is very important. This example by some work in Ethiopia and Nepal, and they try to introduce different health governance structures and community level to involve more actors. Next. But when it comes to health system strengthening and analysis, I think, again, all frameworks go back to the 6 building blocks. Next, I'm trying to be quick. So looking at the Syria example, so what I've done over the last 4 years in my PhD, I try to look at the examples similar to the examples presented by Dr. Munzer, by Zaidoun, Dr. Nasir, and all the NGOs. So interviewed more than 38 people, and also we've done more than 8 focus group discussions. I'm not going through the methodology here, but we try to conclude some concepts and principles for health system strengthening that those are usually missing from the literature. That maybe some people talk about training health workforce, but maybe they do not talk about maybe engagement of diaspora or investing in local resources. So some of the principles, including even, for example, trust. And trust is very important in conflict settings. Social responsibility in Syria stood out to be really an important element here, because medical doctors especially, and all health workforce generally, they do have this sense of social responsibility, that the community perceive them as people who have more influence and have well educated, so they have more social responsibility. So that's why they need to think about improving systems. And this element should be considered when we think about health system strengthening and all of the other elements. Next, trying to go quickly through this. Skills, for example, as well. A lot of people talk about capacity building generally for health workforce, for health system strengthening. What about, for example, policy making? And this is really important in complex settings, because usually with the collapse of systems, you would not have effective policies. And effective policy making, I think, training and skills is very important. And also something like health diplomacy, which is not, very well mentioned in health system strengthening literature. It is important, and I believe I worked closely with Dr. Moder on some issues when he was in Idlib attacks, right? I do believe that because of good health diplomacy skills, he was able to achieve some sort of issues. I know, for example, that Dr. Nasir now, because of his health diplomacy, he's able to lead the health working group effectively. Next. There are some structural issues as well. Some of the issues, as mentioned, diaspora, community networks, bottom-up legitimacy, which is very important. I think the health system in Syria, they introduced the values of democracy in different ways, and this had an issue and impact on health outcomes. And I think there is one clear example when there was an incident for measles in one of the measles campaign. There were more than 15 children, I think 16 children died during vaccination campaign in September 2015. And because this system in northwest of Syria that was built using bottom up, they were having very good trust from the community. So in less than 1 year, they were able to re-establish the same vaccination campaign in the same locations. And I think this might, if this happened elsewhere, when 16 children died, I think the effect of on vaccination coverage will last years. For example, even here in the UK, in 1994, when there was one article in The Lancet on the MMR vaccine, the impact lasted for 7-8 years or even more. But look at the trust and also the impact of bottom-up legitimacy. Next, processes as well as part of health system strengthening. I mentioned community empowerment and engagement. I think it's very important to be sensitive here, because we know that some parties to the conflict might have, different human rights issues. So there could be some conditionality in terms of how to engage with those parties. We know, for example, we are talking about engaging with the local health authority, for example, in northeast of Syria, but then there could be some conditionality and incentives in relation to how to engage with them. And also we mentioned local priority settings, and integration with other sectors to magnify impact, and also to have more a magnified impact of health system strengthening. So those are examples of concepts and principles that I believe that they are missing from the literature when we talk about health system strengthening. We should try to mainstream these concepts and principles within the research related to health system strengthening, and hopefully that what we are trying to do in our 4SSS project in collaboration with the other partners. Thank you.
Thank you very much. Thank you. I'm sorry, but we're supposed to be finishing by 4 because King's College, they want the room by 4. So we are a bit late. So
Dr. Nasir, maybe.
Dr. Nasir, I'm sorry, I just saw, do you have any kind of feedback before we finish? Yeah.
Yeah, just responding to what Dr. Zaidoun said. He put a very pessimistic and disappointing picture of the current situation and what can we do. And then he put the ball in the court of the health fraternity that we should do something, that we should have beyond the boundaries of political divide, we should develop something that is common. So just for him, I think it's easier for us in Northeast and Northwest to work together. For example, I'll give you example. A primary healthcare package that Northwest initially developed. We worked on it and we have finalized it. And similarly, there is one organization which is doing surveillance in both Northwest and Northeast. It's a third party, it's a non-governmental entity, but they are helping us. They are based in Turkey, but they are doing surveillance in Northeast. They are giving us information about some of the outbreaks that is happening in our region as well. And similarly, and it has been challenged to speak with people sitting in Damascus. It has been difficult, but even this cholera outbreak, they have brought all of us together. We actually meet every week. We share the information because this cholera has affected the whole country, even though it's more in Northeast. And we are talking to each other. We are sharing information. We are working on how can we address the issue. And even vaccination that Damascus is trying to bring in, they are going to give more to Northeast. So I think if we, as Dr. Zaidun said, if we, the health people, talk to each other and look things from health systems perspective, it will be easier to work with each other. It is still, I think, a long shot to think about a uniform health system across all three regions, at least in near future. But at least we can collaborate with each other, and because the outbreaks and diseases, they don't follow any boundary, and they can affect any region. So just want to say that in spite of all this bleak picture, there is some optimism there, particularly the partners, the NGOs who are supporting in both Northeast, East and Northwest region. They are playing a very important role. One partner is supporting a training institute in Northwest. They want to replicate the same thing in Northeast as well. And we are grateful to the donors who are willing to support such intervention. So maybe we can first bring two North regions together, and then maybe we can think about the South and rest of the country. Thank you. That's it I wanted to say.
Thank you very much for your optimistic note. We needed it, believe me. Anyway, so thank you very much. I don't know if, do you like to give a closing comment, Karim?
No, I would like really to thank all the researchers who really presented today. I personally learned a lot from, listening to all of although I spent the last 5 years really researching every single paper on Syria, but I learned a lot today. So really fascinating to see, all different levels of researchers, NGOs, practitioners, talking to each other, and this, which is really the main purpose of this conference. This conference started 4 years ago. The idea was from our colleagues in France.
Yes.
We had, and then, the whole idea was that we need to bring people to talk to each other because we are facing the same challenges. We do not want academia to work in isolation, and we do not want NGOs to work without an evidence base. So hopefully this conference will continue to bring people together to advance these collaborations. And hopefully we move in Syria, we move gradually from the humanitarian phase to early recovery development, using evidence-based and research to inform the national level of planning. So yeah, thank you very much. Inshallah. One note here, thank you for the reminder. So after the conference, we will try to run a mentorship scheme. So we asked those who registered, especially for abstracts, if they are interested in joining the mentorship scheme. So we will send emails to all of you to explore further this mentorship scheme. And the idea is to link researchers from the UK with, and all around the world, with researchers and NGOs practitioners inside Syria. Because we are receiving in the R4Syria's project and our partners, we are receiving requests from researchers inside Syria that they would like to research a certain issue, but they do not have the research capacity or skills. So if we can match them with a mentor who can support them and also jointly produce research supported by our group, then I think this is the idea. So you will be contacted in case you would like to take part in this mentorship scheme. Thank you.
Thank you very much. Thank you. And enjoy your evening. Yeah.
Thank you.
Thank you.